Okay, we're preparing to go live. I'll let you know when we're live, and then we can start right at 9.
Okay.
Okay, we are live, and you can start at any within the minute.
All right. So it's 8 a.m. We'll call the meeting to order. Leslie, you want to take a roll call?
Yes, sir. Thank you, Chairman. Good morning, everyone. I'll start with our voting commissioners. Dr. Khan,
Present.
Dr. Barron,
Here.
Teresa Bohannon,
Here.
Jessica Flood,
Here.
Flo Khan. We'll circle back. Yarleni Roadugan,
Here.
Mommy.
Sean Shaner. Sean with us yet? Dr. Slonim,
Present.
Mason Van Howling. Is Mason here? I know Bobette Bond is going to have a late start with us. Do we know where Flo Khan is, or Sean Shaner or Mason? We heard from them.
I have not heard that they weren't attending, Leslie, so I think they may be just joining us late. Do we have a count enough for a quorum? I thought we did.
Yes, ma'am, we do.
Okay, great.
Okay, so
Okay,
thank you.
Our advisory commission members, we would have Justin Prajak. I thought I saw Justin here. Yep, I see him.
Here, sorry.
Barbara Richardson.
Hello.
Good morning. And I believe Director Whitley was going to be late this morning as well.
I see Sean just joined.
Oh, okay, good. Sean Shainer's here. That
Yeah, and-
concludes our roll call, and we do have a quorum.
Thank you, Leslie. Next item is for public comment. Anybody in the north, please remember the comments are limited to 3 minutes each, so kindly stay within that time frame. Any comments in the north, public?
Chair Khan, let me ask the members of the public who are joining us today, if you're on the phone and would like to speak during public comment, please indicate that by pressing *9 on your phone, or if you're joining us via Zoom participation, go ahead and raise your hand and I will call on you. Looks like we have one caller, Chair Khan. Let me allow him. So, Mr. Tom Clark.
Could you please identify yourself and who you represent, yourself or an organization?
Thank you, Mr.
Can't hear you.
Okay, it looks like there might be a...
Is that better?
Yeah, we can hear you. Yep.
Members of the commission, my name is Tom Clark. I'm here on behalf of the Nevada Association of Health Plans. We are the association that represents the private carriers here in the state. And I just wanted to take this brief time here during public comment to discuss a little bit about Senate Bill 40, which I know your executive director, Ms. Chilhagian, will discuss later on in the agenda. But we worked closely with the executive director. We worked with Senator Ratty in a rare instance of legislative coalition building. We worked with the Nevada Medical Association, the Nevada Hospital Association, and the PCMA to come up with amendments. It's really important for me to stress that the work that you all have done on the all-payer claims database on what became Senate Bill 40 was a fantastic foundation for us to work with. We had some things that we thought were important that needed to be addressed, and we think that they were done so in the amendments that make up the first reprint, we wanted to make sure that we tightened up the governance of the APCD with the creation of the advisory commission. We wanted to ensure that the data that was going to be collected was relevant to the discussion, and that the data that was collected protected the patient, the provider, and of course, my clients, the insurance companies. And then finally, the distribution of that data was done in a way that was going to ultimately benefit, the healthcare system as a whole here in Nevada. So we appreciate everyone's hard work today. Looking at the first reprint, it looks pretty clean to me. Of course, it's legislation, so who knows if there are going to be future changes to it. But I can promise you that we will be at the table working again with your executive director and the other stakeholders in this effort. So thank you very much. I appreciate your time, and it's early after a long deadline day, so we will figure out what was created over the last 24 hours. Thank you, Mr. Chair.
Thank you. Appreciate your input. Anyone else on the public comment, north or south?
Chair Khan, it looks like that concludes public comment.
Thank you. So the next item 3 is approval of March 15th minutes. I presume everybody has had a chance to look at them. Do I have a motion to approve the minutes?
This is Tony. I'll move.
And second, anybody second? Okay. All those in favor?
Aye.
Aye.
All right, so the motion carries. So the item number 4, what we have done is try to allocate time for each item so we don't get dragged on for a long one. And I just to remind everybody, unfortunately or fortunately, I have a hard stop at 12 on another conference call. So we'd like to try and keep within the time frame. So item number 4 for Bossa, it says discussion on PPC recommended principles and operating procedures for benchmark strategy development. Sarah, you want to elaborate on that?
Sure. Thank you, Chair Khan. Members, if you recall, this is the operating procedures in which we had a discussion at your last meeting, and I have then since circulated and sent to you in between our meetings for solicitation and feedback and to address any concerns. I believe I've connected with those who had questions, but if I can, I'm actually going to turn this over to Mr. Michael Baylett to give a little bit of a background or recap on why this is in front of you today.
Thanks, Sarah. Good morning, Commission members. The context for this document is that as we began working with Sarah and thinking about how to proceed through a process of developing a set of recommendations for a cost growth benchmark methodology, we became aware that right now the Commission doesn't have bylaws or operating procedures that inform how it makes decisions. And we thought that it would be helpful, at least for the purpose of the cost growth benchmark methodology development, for you to have such guidelines, because we will be presenting to you, in fact, starting today, a series of decisions where you can make recommendations in terms of how the benchmark strategy should be crafted. And so this document is modeled off of a similar document that was adopted by a parallel body in Oregon. And so the language that is in there doesn't reflect actually anything having to do with how you have worked together in the past, but rather sets forth suggested set of first principles and then just parameters for making decisions, documenting decisions, and conducting this process.
Great, thank you, Michael. So Chair Collins, if you would like to consider taking a motion from one of your commission members to adopt these, if you see the value in it. Again, this is just because the commission doesn't have any current set of bylaws or operating procedures, and this is only in regards to the benchmark work.
So my observation on this is I'm presuming everybody got the draft right? So since everybody has a chance to look at it, are there any questions on that? If not, then we can proceed to for possible adoption. Does anybody have any questions on those procedures that were circulated as a draft?
Dr. Sonam has a question.
Thank you, Sarah.
Go
Thank
ahead.
you, Chair Khan. Just one quick question. Given, I guess this is a question for Attorney General Ott more than anything, but anybody can help me here. Given that we have already an approach and we've got open meeting law guidance and we've been making decisions as a commission for the last however long we've been in existence, I just want to make sure technically that we're not conflicting with anything that comes out of our charter from the governor's office as we've been set upon to do our work. We've been making decisions. We go with a majority or a quorum, and we make sure we have a quorum. We go with a majority, simple majority voting. I'm trying to figure out, making sure that we are consistent to the charter, I guess is the point.
So Greg, you want to answer that?
Yeah, Deputy Attorney General Greg Ott. Fair question, Dr. Slonim. One of the first things I believe Executive Director Chilhagian did was send me a copy of that so that I could make that review. I did make substantial changes because the form we had was from Oregon, so tailored it to Nevada law, tried to make sure that it was consistent with your founding document. I don't think Sarah has made any substantive changes that would cause me to do a re-review since then, but she can correct me if I'm wrong, but that was one of the things, that was one of our concerns as well. So we did do that review.
Yeah,
Thank you.
Thank you so much, Attorney Ott and Dr. Sonam. I should have recapped that as well. There's been no changes or modifications to the document, and it does reflect your version, Greg.
Any other comments on that before we go for possible action on these operating procedures? None? Dr. Barron?
One question, or just a clarification. I think I heard Sarah say that that the recommendations put forth are specific to this to the Peterson Millbank project, and should this commission decide to draw up governing principles for all of its work in the future, that this list of principles would not necessarily supersede that. Am I understanding correctly our plan?
Greg? I see you nodding.
Deputy Attorney General Greg Ott, yeah, that's the way it was drawn up. It was meant to be specific to this work. Certainly some of those things could apply if you wanted to adopt bylaws later on, but the document was specific to this work.
Okay, just want to make sure before we vote.
All right, we have Jessica Flood, Commissioner.
Yeah, thanks. This is Jessica. I really appreciate this start at formalization for the Patient Protection Commission. It's nice to kind of have a common understanding of how to move forward, because I think that's actually caused some tension in the past in the commission. And like Howard said, or sorry, Commissioner Barron, I hope that we can move towards bylaws in the future. So I'd be happy to make a motion if we're at that place.
I think so, unless somebody has any other observation, I'll take that as a motion. Is there a second? Any seconds?
I'll second.
Dr. Barron seconds it. Any opposed to this? If none, the motion carries. Thank you. All right, the item number 5, this might cause back pain for all of us. It's 75 minutes allocated. Certainly for me, it may. So having said that, we have a presentation, as we discussed last time, following up on that, on cost growth, benchmark methodology, etc., defining total healthcare expenditure, defining the population for whom total healthcare expenditure are being measured, and establishing criteria for choosing an economic indicator. And we have Michael Bailett, president of Bailett Health. So could we proceed with that? And please hold your questions if you have any once the discussion is completed.
Thank you, Chair Khan. I will attempt to make sure that nobody suffers back injury through this next part of the meeting. So, as you will recall, in March, we reviewed how some other states have designed and implemented healthcare cost growth benchmarks and how they've complemented that work with data analysis to try to understand what's driving healthcare spending and spending growth. Today, we're going to start a multi-meeting process to design what you all think Nevada's approach should be. I will be presenting to you today and in future meetings a series of what I will refer to as design decisions that collectively will define your benchmark methodology. When I do so, I will explain the concept and invite questions from all of you just to make sure that you're clear about the ideas that I'm laying out. I will share with you what approaches other states have taken. In some instances, the states have moved in concert. In other instances, they have not. And I will describe that for you. And then I will ask you for your recommendations. These won't be final recommendations because there'll be an opportunity for you to iterate if you want to. In addition, I know that we're going to talk later on in the meeting about a possible subcommittee that might be providing input to you in the process. And if you go forward with such a subcommittee, then between each of your meetings, we will solicit input on what you have discussed from that group and then bring their feedback back to you. So I would say, as I present the design decisions today and I ask for your recommendations, let's consider those to be interim recommendations, and your final recommendations will really be after we've gone through the whole process.
All right.
Okay.
Yep.
All right, so we're going to focus on 3 design decisions today. You can see them laid out here, and I will move through them sequentially. The first question is to define what is the spending that we're going to be measuring relative to the benchmark. And the term for the total spending that I want to introduce today is total healthcare expenditures. So total healthcare expenditures is what we'll use to assess performance against the benchmark. I'm going to review the components of total healthcare expenditures as adopted in other states, and then ask you how you think the term should be defined. There are 3 broad categories of total healthcare expenditures. The first represents payments made by payers, public and private, for medical expenses, often in the form of a claim payment, but also for also in the form of non-claims-based payments. 2, member cost sharing, and 3, something referred to here as the net cost of private health insurance. So I'm going to move through each of these sequentially and invite your questions should you have any. So starting first with this category. So first, we're talking about payments by payers to providers. I want to note, incidentally, that I've modified this slide and one other a little bit from the presentation that was sent out to you in advance of the meeting. And so we'll make available to you after the meeting this final presentation set. So payments by payers to providers as the first category of total healthcare expenditures, and it includes claim-based payments for reimbursement for the cost of healthcare services provided to members covered by a public or private plan, and non-claims-based payments, which is any payment that is not associated with a claim. The claims-based payments are typically for covered services, and I want to note that the definition of covered services varies by market. So for example, long-term care is covered by Medicaid. It represents a large portion of the Medicaid budget, but it's not a service that's covered by a commercial health insurance policy. So when we tally up payments to providers for covered services, just be aware that the service definitions are somewhat variable. When we look at claims-based payments, these are the typical broad categories by which other states are collecting data. There obviously there's a lot of detail underneath this, but the reporting of claims-based payments for benchmark calculation purposes, just as a reminder from our first meeting, is reporting by payers of aggregate data. So when they report aggregate spending, it doesn't get any more detailed than broad categories like this. Okay, for more nuanced analysis, that's the data use strategy that we talked about at the last meeting that involves drilling down into claim-based data. In time, it will be drilling down into your all payer claims database should the bill move forward. And on an interim basis, it's going to be focusing on claim data for the public employee health plan and for Medicaid. I want to note, you see the footnote for retail pharmacy. There really are two components of pharmacy spending, and pharmacy spending has been over the last several years one of the fastest growing areas of spending. So I just want to note retail pharmacy is distinct from what we sometimes refer to as medical pharmacy. So this is clinician administered drugs, and those that spending typically falls into hospital spending categories or sometimes professional spending categories.
Ask a question on that real quick.
Sure.
In that spending data, oftentimes they don't account for the rebates and discounts, which can inflate the cost or the spending in the particular category. How is that accounted for, or how do you, is that going to be later in the presentation?
Yeah.
Okay, thank you.
Yeah, no, thank you for raising it. It's a big issue for pharmacy. And so we will talk about that a little bit later when we get to non-claims-based payments.
Perfect, thank you.
Yeah, thanks for asking.
One other quick question, if you don't mind. What from the claims-based approach, one of the things I'm not seeing is care for mental illness. And so where is that, because that can be substantive in terms of cost and time, where is that in the mix?
Yeah, so when we're talking about claims-based payments, it's really all spending for all claims. So these broad categories, they're very broad, but you would find mental illness in multiple categories here. So just know that if it's a covered service and there's a claim payment made, we're including it in the definition. Be it for Medicare, Medicaid, commercial, it's included.
Mr. Chair, this is Sean.
These broad categories are not obviously detailed. Yes, sorry.
This is Sean Shaner. When you say commercial, is that for both fully insured and self-funded, all commercial payers?
Yes, all commercial payers. Any other questions about this?
I have a quick question. When you're looking at these claims, would it be only claims for services within our state or for services outside of our state?
Yeah, thanks, Teresa. We're going to talk about that a little bit later. We're going to talk about where the services are delivered and where people reside. So that will be a separate conversation we have a little bit later. Okay, so the first question really that I'm posing to you, and the questions will get harder over time, this one is, I think, not so hard, is when we talk about including claims-based payments.
I can't hear you. Can others hear him?
All right, I'll raise my voice.
No, now we can.
All right, so the first question that I want to pose, and I think this is one of the simpler decisions that I'm going to ask you to make, is when we define total healthcare expenditures and we think about claims-based payment, do you want to include in your definition all claims-based payments for covered services? I think this is pretty straightforward, but this is the first decision.
And so what's the alternative to that?
Claims-based payments for only some services. That would be the alternative. Every other state has adopted a definition that they want to include all claims-based spending for covered services.
Okay, so it's kind of common sense to just like do it for all services.
I think so.
Okay. That sounds reasonable to me.
Okay, anybody object?
So following our newly adopted rules, do we need to vote, or how does it work?
So the operating principles actually state that you will make decisions by consensus, and that you'll only vote if you can come to agreement, or if one of you says, I'd like to have a vote. So I would say for our process right now, if I look at your smiling faces and you are nodding your heads and nobody's saying no, then we'll consider that to be consensus.
And if I can add to that too, I'm sorry, Chair.
No, but what I'm saying is, do we want to move on taking a vote on some items that you want, or consensus as we proceed, or collectively in the end?
I think it makes sense for you to have a formal vote in the end on your full package of recommendations. But as we go through all these incremental decisions, I think a consensus assessment of whether you all feel comfortable is sufficient.
Okay, Sarah, what do you have to say?
Yeah, and if I can add to that, so the way with compliance with open meeting law, and Greg, you can correct me if I'm wrong, but as you guys are having these discussions, and if you build consensus, I think, and there's no disagreement, then you continue to move forward. If there is a disagreement and then you really want to have a roll call vote, at that time we will pause it, we'll note it, and then it'll be agendized for our next meeting for you to take a formal roll call vote. And so for the purposes of our discussions today, consensus is okay. If you can't reach there, can't get there, we'll pause, note it, and then we'll put it on the agenda for our next meeting for a formal action.
Greg, you agree with that? Greg,
I'm fine with that approach.
That's the right thing. Okay, all right. So let's proceed. So maybe we can take this while we are at it. Is there anybody opposed to this right now? So let's put it this way.
Can I ask a question?
Yes, please.
The language for covered services is what is really standing out to me. So I guess what about, like, what, I guess, can you explain that to me? Because obviously plans don't cover all services. So where would that fall? That kind of, I mean, I guess I'm trying to understand, is there anything that's going to be missing if it's not a covered service?
So yeah, there'll be certain forms of spending that people incur that is not included. For example, if someone's enrolled in a commercial health plan and they want to have cosmetic surgery and that's not covered and they're paying for it out of pocket, we would not be including that in our spending calculation.
But I think even outside of like cosmetic stuff, I mean, we had a situation here in Reno where there was a couple who had a baby that needed a specific type of medication that cost $2 million. The insurance company was denying it. So I'm concerned about that type of thing, that type of situation. Or, I mean, just the types of costs that you incur that insurance would never cover: transportation, you know, hotels. I mean, all the things that come with, you know, those sort of, with healthcare that is outside of what insurance covers. So I guess that'd be my only concern, and something that I'd want to make sure that is somehow captured somewhere else. And maybe that's another conversation. I just want to be clear on that.
Yeah. So there are both practical and philosophical considerations here. I'm going to focus on the practical one because that's the most, I think, the most constraining one. there is no means for gathering data systematically and completely on spending that people make out of their own pockets for non-covered services. We have a data source for covered services that, because there are payments that are made by payers, but if you or I were to make payment for something that wasn't covered, that was a healthcare service, the commission collectively would have no source for obtaining that information.
So if I may, I agree with you that's not possible from a practical point of view to collect that data. Is it at all possible to sort of solicit information, if at all, from the payors, it'll be each payer, what services they're not covering? And one can kind of come to a sort of a ballpark figure. Well, generally speaking, like transportation is not covered, or this is not covered, or that is not covered, and have a ballpark that would approximately cost this in this market. And so this is the ballpark that would be the cost outside. However, word of caution for that, the managed care organization would have to cooperate to give the lists of uncovered services in each one of them. And then you come with a possible sort of calculation on that. I would like to hear Sean's opinion on that. He is from managed care. Before you answer, Sean?
Yeah, thank you, Mr. Chair. Sean Shaner for the record. We list out in our explanation of benefits, our summary plan documents, what services are covered and are not covered. As Michael mentioned, the cosmetic surgery is the classic example of services that are not covered. There are certain instances where transportation services are covered or hotel services are covered, depending upon circumstances like transplants, for instance, in certain instances are covered. So the information's available. I personally agree with not including excluded services for the purposes of calculating total healthcare expenditures for this exercise. But the information is readily available as to what is and is not covered by various health plans.
And so I appreciate that input, and that's my concern. It may be a very major undertaking to try to come to some decision of ballparking these figures, and they will not necessarily be accurate, obviously. So I just wanted to kind of clarify that. So go ahead, keep your presentation going.
Okay, so I think it's right for us to acknowledge that there is some spending that occurs for healthcare services that are not included in this definition. I think this definition is broadly inclusive, but it's not fully inclusive. Okay, so it seems like there is general agreement on this. So let me go to the next category of spending by payers, which is non-claims-based spending. And we've categorized non-claims-based spending for you into 6 categories. And I will note that non-claims-based spending relative to claims-based spending is a smaller percentage of total payments from payers, but the percentage that is non-claims-based has been growing and is projected to grow. So the first category is prospective service payments. So claims payments are made retrospectively, but there are arrangements where payers pay providers prospectively. Sometimes this is capitation, where there's a per person payment made. Sometimes there's a prospective payment for an episode of care. Sometimes there's a prospective payment for a case rate, such as maternity care, prenatal through postpartum care is a case rate sometimes. Second category is performance incentive payments. This is broad to include incentive payments for anything. So it's commonly the case that incentive payments are made for quality improvement, but it can be for cost reduction or infrastructure development. It can be in budget-based contracts for distributions of shared savings or even shared risk recoupments. So this is our broad category of incentive payments. Third are what we are terming population health and infrastructure payments. So these are payments to help providers develop and sometimes sustain capacity to do things like coordinate care, manage care for very high-risk patients to help keep them at home and stable, for example. The fourth category, provider salaries. This is pretty much limited to payments by organizations that integrate an insurance function and a care delivery function. So there's not a claim payment made because the provider is actually employed by the same organization as is providing the insurance. The fifth category are payment recoupments that might result from a payer's review or audit. And so this is actually a negative non-claims-based payment. And finally, we have an other category to capture types of payments that are not reflected here. For example, Medicaid disproportionate share hospital payments fall into this category. And there are other miscellaneous payments that are non-claims based. So this is what collectively represents non-claims based spending. And when we think about payments made to providers, this is the second category. We've got claims based and non-claims based, and together they represent all of the payments that payers make to providers of services. Does anyone have a question about non-claims based payments, what we mean by this, and about these categories?
Yeah, this is Jessica. This may be a stupid question, or it may have been answered in the last meeting. But for people who are uninsured, so there's spending, hospital spending on those people. Is that captured anywhere? Because that is a large percentage of the population in Nevada, right? We have more uninsured.
It's a great question. So there are two ways I want to answer it. One is when we're talking about spending, we're talking about spending by payers and by, we're talking about spending by payers and not by providers. So the provider spending, the provider cost is not what we're measuring. We're measuring about outflows of dollars to healthcare providers and to a limited degree to health insurers, but not about the actual cost. And we should acknowledge that the two are not the same. Sometimes the payments might be greater than the cost, and sometimes they might be less than the cost, and sometimes there are no payments for the cost, as in the case of someone who's uninsured.
Yeah. So in some ways, it's kind of like we're acknowledging at baseline, there's going to be costs that happen that just encompass all provider costs. But we are just trying to limit that growth moving forward.
We're focused on trying to constrain the rate of growth of payments that go out to providers universally.
Yeah, so we're not trying to.
It's growing every year. We're not actually, by setting a benchmark, trying to reduce it. We're just trying to constrain the rate of growth.
Okay, thanks.
Okay.
I appreciate
Michael, this is Howard Barron. Question on in that regard. Although it is true that it may be that this model does not calculate the deficit that is created by a payment not equaling the cost of providing the service. For example, in Nevada, hospitals that are very Medicaid centric oftentimes will quote somewhere in the neighborhood of about 55 cents on the dollar that they are getting reimbursed based upon their cost. And so that those losses are, I mean, typically, I guess in the economic model that we have of healthcare in our country are made up by the commercial payers, right? The better than Medicaid or Medicare rates that hospitals can negotiate with payers for reimbursement. And in limiting the rate of cost growth, which, in principle, I'm certainly in favor of, should we not be accounting for the significant losses that hospitals and providers and so forth take on a substantial portion of our population in terms of reimbursement? And so it just seems to me that's a big chunk that really would have a significant input in where we set our benchmarks, and wouldn't we be blinding ourselves if we don't have that kind of information?
So, I mean, the benchmark as a strategy is obviously a broad brush strategy. I think what it forces is a consideration then by bodies like this commission. Okay, so what do we need to do to be able to slow healthcare spending growth and at the same time sustain a delivery system? And so that's really the value in having the benchmark. You'll set the benchmark value, but then the important work is you collectively saying, okay, now what are we going to do to make sure that we meet it? And what are the actions that have to be taken?
Right. Well, and what I hear is that this strategy, it's slowing growth, but it's not going to address all these other things that are weird in the system, such as like what Commissioner Barron was saying, where we have low rates of reimbursement for Medicaid. So we, are asking for more for private insurance. So that's already there. We're taking that whole thing into account, just saying with that system moving forward, we still want to slow it down.
Yeah, I mean, that dynamic, Howard, exists in every state. Medicaid is the low payer in every state. Now, the degree to which it's lower than commercial payers, that varies, and it reflects all sorts of things, including market dynamics and leverage and other things. But it is always the case that Medicaid pays less than commercial payers. And that's for multiple reasons. I mean, but one of them is the government, when it's the payer, be it the state or Medicare, has a lot more control over what it pays than the commercial market does.
All right, let's move on.
This is Sean. One question.
Go ahead, Sean.
Sorry about that. Real quick on this provider salaries component. Organizations like myself and Dr. Sloanum's, we serve both as health insurance, managed care, and provider. I want to make sure that we're not double counting dollars that would otherwise be paid for salaries, in that we, the health plan, pay the provider, in our instance, Optum. They in turn employ physicians, but they take money that we pay to them and they pay their physicians. I just want to make sure we're not counting the payments that we pay to Optum and then counting the payments again that they use to pay the salaries, and that we're not double dipping there.
Thanks, Sean. So we're only including salaries in the case where there's no claim payment being made.
But I think, Sean, if I heard you correctly, does that really answer your question?
No, because they provide services, so they would be submitting claims/encounters to us as the organization.
Yep.
It's not like we don't get data back from them. And I don't want to speak for Dr. Sloanum, but I can assure you that at Renown, I'm sure they give data back to Hometown Health. So, there are claims or encounters coming back to us, the health plan, from the provider who we pay money to. So feels like we're double counting that, and it would inflate what would otherwise be the cost.
Yeah, so we wouldn't count salary in that scenario, Sean. And I'm happy to have a follow-up conversation with you if that would be helpful.
I think that would be helpful, because I think what Commissioner Sean is raising really needs to be deciphered a little bit more than we have done. So, and you can take it offline and maybe discuss with him.
We'll do that.
Okay.
Chair Khan, I see there are a couple of other hands raised.
Yeah, I didn't see who had the hand raised.
Teresa and Tony.
Teresa, you want to go first?
Sure. quickly, I just was, if you can go back a slide and the number 3, the population health and practice infrastructure.
Mhm.
Can you explain that one more time to me? Because I think I had asked you on a call about how, how public health spending fits into this. And it sounds like it really doesn't. But then looking at this, it does seem like there is some way, but I think that it's more in terms of not what I was referring to.
These are payments made by insurers, Teresa, and not public health.
Okay.
So sometimes an insurer might enter into what's referred to as a total cost of care contract with a provider, where they set a budget for spending on a per person basis. And as part of the arrangement, the insurer will say, we will give you some money so that you, for example, can have nurse care managers work with your high-risk, expensive patients. And so those payments are not claims-based. Those are what we're calling population health or infrastructure payments, but they're coming from the insurer to the provider. Does that help?
All right. So I think in the interest of time, we need to be cognizant of that also. Any other question?
Just one other question, Dr. Khan, and it relates to that population health piece as well as generally. So we would include those costs, those non-claims-based spending in our model.
Mm-hmm.
Because one of the important things I think for us goes back to the presentation we had in March, which is compared to the other states where we're, just by way of reminder, Michael, make sure I get this right. Compared to the other states that we're comparing ourselves to, right? When we say, by the way, other states have done X, Y, Z, those states are far ahead of us on both the cost curve and the quality curve. And in Nevada, we know we're in the bottom decile consistently in quality. And so this infrastructure investment, I'll call it, needs to be made in Nevada in order to allow us to deliver the kinds of value-based high quality care that we aspire to. But without the inclusion, we will be at risk because we'll keep trying to lower costs without the ability to integrate data, understand practice patterns, et cetera. So I want, if I'm accurate, I think that what's happened is we're comparing ourselves against really high performers and what they've included. I want to make sure we're not that as a state.
You know,
Right.
I don't get the sense that there is a comparison with states because we're really setting our own, like, I see this as a budget, right? We're setting our own budget, our own benchmark. And I don't think, I mean, I totally understand what you're saying, Commissioner Slonim, in terms of we're so far behind, it's overwhelming. But on the other hand, like moving forward, I like that it seems like it just shows kind of, I hate to say like the bad actors, but the outliers of the system that are increasing costs. It's data-driven decision-making is how I see it.
So with all respect, Commissioner Fly, I think the challenge here is, despite, to the point that Commissioner Banner made earlier, which is our Medicaid program pays so low and compared to other states, that there's an inability, if we're not including those costs, like other states, to invest in the programming that helps those people. We will just continue to carve out things if the claims are not included. And that's, I think, the concern. Right. Mental health will get worse. It will deteriorate because we won't be able to make those investments in mental health activities if we're not appropriately accounting for the services that are being provided.
So Michael, you want to respond to that so that we can move on?
Well, I think this is ultimately a question of where you're going to set your benchmark and whether you want to set it higher or lower. Because I think what I'm hearing Tony saying is that there's been underinvestment in Nevada, and for that reason, there needs to be more investment, and other states have made more investment. That's not really a question for us for today. That really gets to where you want to set your benchmark value and whether it should be higher or lower. So I would suggest that for today, we defer further exploration of that. And that you now all just consider the question, do you want to include these 6 categories of non-claims-based spending in your definition that's going to go into that broad total healthcare expenditure category?
All Right,
Can
so
we
I think
suggest
that,
additional things besides just what was listed? Can we?
Go right ahead.
Well, I mean, I had this conversation with you offline, and I do think that our low spending in our public health system contributes to our significant costs in healthcare. And so I would like to somehow integrate our public health programming and how that fits into what Dr. Barron's talking about, what Dr. Sloanum's talking about, and even to an extent what Commissioner Flood is referring to. And that is that because we don't spend the dollars like we should in our programming in chronic disease and other things, we end up at the bottom of the list. And so that then incurs more costs. And so I think if we can somehow capture that, we will do ourselves a favor in the long run. That's
so
just my suggestion.
if I may suggest, why don't we go through the items that they have listed, and if the commissioners have other areas that need to be included other than their points that they are raising, then if you hold your thought and in the end say, I want this additional area considered, please add to your list, or I want this other area considered and please add to the list. So we can add to the list of other areas that are not already inclusive in their points that they are presenting. We certainly have the right to, suggest additions of points of importance.
Chair Khan, isn't the time for that now? This is the end of the section on this slide, right? Isn't the time for additions now?
Mike, how many more items do you have?
This is it. If you want to make additions, this is the time to do it, because this is going to.
Perfect. So I think I would like to go in order, one commissioner at a time. Please raise your hands and give everybody a chance for their individual questions rather than just one person asking multiple questions. So if you could hold all your questions for your turn, that would help streamlining the process. So Sarah, you want to proceed with, make sure every commissioner has an opportunity to say something that they want to say?
Sure. Let's start with Commissioner Flo Khan.
Oh, thank you, Sarah. The only thing I would say is, yes, we like the idea of having all services, so all covered services included to ensure that we're collecting data on everything. So I appreciate the presentation. The only addition that we would like to see, and I don't know if this is the appropriate area to put it in, Michael, so you tell me, but we would like to see from a pharmacy perspective, we would like to see the rebates and discounts included somehow or captured somehow within the data. And I don't know if that's later.
Yeah, so you know what, let me talk about that right now, because it's the next slide.
Oh, okay. Thank you.
Right. So so drug rebates is a big issue. They can equal about half of Medicaid prescription drug spending, and in Rhode Island, they are about 15% of commercial spending. So in the 5 states that are currently operational with their cost growth benchmark programs, they have payers reporting prescription drug rebates received, and total medical expense, which includes the claims and the non-claims-based payments, is reported net of rebates. Okay, and so we had this teed up as a separate question, but my suggestion to all of you is that you would include prescription drug rebates as a form of non-claims-based spending. It's actually negative spending because it's a rebate. It's an offset to spending. You'll note here, Flo, we don't have the discount cards because there's no way to systematically collect data on dollars associated with them. And I know that for certain drugs, they're significant, but there's just no basis for us to gather the information.
All right, next commissioner.
Let's go to Commissioner Howard Barron.
So 2 comments. One is going back to the provider salaries that Dr. Sloanum was mentioning. I too would be concerned about adding or putting those in, and I think Commissioner Shaner also mentioned this. To me, most instances of provider salaries are sort of the cost of doing business if the payer is employing the provider or the hospital's employing the provider, and I'm not sure how you would I would be also concerned, as was Sean, that we would be double counting providers who are also collecting on claims that they're submitting. So I'd like to see that fleshed out a little bit more, and I know you're going to have an offline conversation about it. With regard to other payments, I think that I think there's been some good points raised about all of the non-claims-based spending that occurs in healthcare, including pharmacy rebates and including out-of-pocket expenses for patients and families. We see that every day in my practice. Things that people with very, very high-end commercial insurance that still have benefits that they're paying for out of pocket that are not covered. And I think that when push comes to shove, that adds up to a lot of money that's spent out of pocket. And of course, the goal of the Patient Protection Commission is to protect patients, and in setting benchmarks, we would like to see that trickle down to an improvement in benefits to patients and improvement in their spending out of pocket. And the offline conversation I had with you, Michael, you kind of acknowledged that in the other states that have gone through this process, we so far don't have any data that specifically says that setting these benchmarks actually improves out-of-pocket expense for citizens. And that's something that I think we need to acknowledge in this process. Those are my comments.
So if I may just add to what Commissioner Barron has just said, the out-of-pocket expenses are not just non-covered services. Keep in mind, they also include deductibles, in some cases, which are very high deductibles, especially with this Affordable Care Act. Some insurers offered services with 5,000 deductible, that's out of pocket, and the co-pays, which are there with every service they receive in a covered benefit, they still have a co-pay. So that's also out-of-pocket expense. So keep that in mind when you're looking at this, please, Mike. All right, next Commissioner.
Got Commissioner Jessica Flood.
Thank you. I really appreciate Commissioner Barron's comments on, I think even Michael noted that earlier in this presentation, that is it Massachusetts, or maybe it was in the last presentation, that Massachusetts is still seeing higher spending out-of-pocket expenses despite this work. But I guess from my point of view, I see this, how do you eat an elephant one bite at a time? This is one bite of the elephant where we can really get more data and make data-driven decision-making. So I just want to make sure, I think it's easy to want to cram everything into this, but it's a snapshot in one part of the sector. That's at least how I see it. So I have no additions to make for this.
Thank you. Next Commissioner.
Hey, Commissioner Sean Shaner.
Sean, are you on mute?
Okay, we can circle back to him.
Okay.
Commissioner Teresa Bohannon.
I kind of made my comment. So just for clarity though, because we do not in Nevada have an all payers claims database, we would be relying on basically PEB and Medicaid, Medicare. Is that correct?
No, the data that's collected for the benchmark would come from the payers. So it would come from the individual health plans. It would come from Medicaid for payments outside of the Medicaid MCOs, and it would come from CMS for traditional Medicare at a minimum. The use of PEB and Medicaid would be for your complementary data analysis to drill down into what's driving healthcare spending. But measurement against the benchmark is aggregate spending reporting from the payers to the state.
All right, thank you. Next Commissioner.
We have Commissioner Yarleni Roa-Dugan.
Hi, thank you. I don't have any questions for the presentation, but I would like to add that, like the other commissioner said, I think this is a step in the right direction in terms of helping our patients and our community to have affordable health care, or at least to see where the money is going.
Thank you. The next commissioner, Sarah.
Commissioner Sean Shaner.
Sean, are you back on or are you on mute? Maybe having technical issues, maybe.
So, Chair Khan, I do want to acknowledge that two commissioners are not in attendance. Right now, we've got Commissioner Bobette Bond and Commissioner Mason Van Houweling. So what I would like to propose is that I connect with them offline with Michael to get some additional feedback in case they have any additions as well. And unless there is an objection to that, I just want to make sure that the commission is aware that I will do that offline after the meeting.
I think that would be appropriate so that everybody has an opportunity to, give their thoughts so that it's more a consensus-based, process that everybody is hopefully on the same page.
Okay, great.
Sorry,
right.
Sarah, I didn't get called on, so I have some issues.
So I'm so sorry, Dr. Slonum.
Two comments and then I'll get back. My aforementioned comment about population health and the physician piece is important. Two other important pieces. One, given how low we're reimbursing for Medicaid, if there's a Medicaid fee increase, how will that get counted against the benchmark in the state for trying to reduce total cost of care? That's question one. Question two, what about for this non-claims-based spending for insurers, where does profit fit in, right? So you could drive profit in a way that could be delivered to better care, for example. And so that's a non-claims-based spending opportunity as well. As you're making shareholder returns, that money is going out of state. That shouldn't that be in here somewhere?
It is. It's in a later category that we haven't got to yet.
Okay. And what about the Medicaid conversation about total cost of care? So imagine that
any
right
increase
now
in
we're
Medicaid
dealing with
spending is going to go into, the total spending. I think the broader question here is how do you interpret performance against the benchmark in the future? So I'm not recommending this, but let's say theoretically the state legislature decided it wanted to make a big investment in increasing payments through Medicaid. And as a result, the trend rate for Medicaid exceeded the benchmark in a given year. It would be possible then to interpret the performance of the Medicaid program and say, well, it was above the trend rate, but there was a conscious decision as part of state public policy to put more money into Medicaid. And so we consider that to be a justifiable reason why the benchmark was exceeded.
and then it resets to next year as you come up with.
You keep measuring it every year. Okay. So at the end of each year, when you measure performance, and you might recall it's going to be at 4 levels potentially, potentially state, market, insurer, and large provider entity. There should be an assessment at the end of the year, not only of whether the benchmark was met or not, but whether exceeding the benchmark happened for reasonable or justifiable reasons. For example, we expect healthcare spending in the United States to go up in 2021 over 2020 at a fair clip because people stopped accessing care altogether in the early part of 2020. So I would expect that all the states that have cost growth benchmarks will see that benchmark exceeded for 2021. And the reason will be because there was artificially depressed spending in 2020 due to the pandemic. Okay. And people will understand that.
Very good. Thank you. The other question I have for Chair Khan and for Sarah, I'm perfectly fine getting input from other commissioners who weren't able to make it this morning. But again, want to go back to our process. I always hold us accountable to the process. We just approved guiding principles about how we were going to make decisions. We have a quorum in the meeting, and now we're trying to, I don't know what we're doing. So if we go offline, the value of us all being together is we can feed off of one another for questions and iterations of our understanding. And here's actually Commissioner Van Helling just joined us. So I'm wondering about a separate process offline that pulls us out of the meetings process.
I think I can answer that, and then I'll defer to our attorney if there is something that is not compliant with our open meeting law. So the way I anticipate facilitating that, because we want to ensure that everyone does have equal access to this presentation and participation. So I would engage with the commissioners who missed this, and this would apply to any one of you if you were not able to meet a meeting, and make sure that you saw the materials, had questions or any concerns raised, but nothing would be incorporated or included as a consensus until it's brought back to the entire commission. So for instance, Dr. Slonim, if there was concerns that either Commissioner Bond raised or Commissioner Van Helling raised, I would collect it, and then at the next meeting, we would report on their feedback and then bring it back to this commission to agree to add those or not add those, and then have a discussion. So the only thing that's going to be taken offline is basically just a kind of a check-in to make sure that they saw this materials and they had an opportunity to provide the same feedback, but nothing would be included until it was brought back into the commission.
Thank you.
And I believe that is still okay and in compliance with the open meeting law, because it's not about me facilitating any discussions outside of the meetings. It's just me following up with one individual commissioner and then reporting back to the commission at the next meeting. Chair Khan, you're talking, but I'm sorry, you're on mute.
Sorry. So my thought on this is, and Greg can elaborate, is we do solicit in writing input in the public comment from organizations who want to give their opinion. If they are not present in person, they can give their recommendations, suggestions, or observations in writing to us, so they become a part of the record. So basically that's what we are doing, but we are not, like Sarah said, acting on that unilaterally or arbitrarily, unless it's brought back to the commission, deliberated, and then voted on or otherwise. Greg, you have any thoughts? Did we lose Greg, or is he on mute?
No, I'm here. Sorry, I was unmuting, Chair Khan. Deputy Attorney General Greg, I don't have anything to add to that. I think that's consistent with OML.
All right. All right, thank you.
Dr. Slonim, does that address your concern? Okay, great.
All right, and next commissioner, please.
That concludes all the commissioners.
Is Sean back? Sean Shona back?
Sorry, Commissioner Sean Shaner?
Okay, I think we lost him.
Okay, and then it would just be if you had any additions, Chair Khan.
No, I don't. So let's go back to where are we? Just keep in mind our timing. I hope, Sarah, you're keeping track of our time, the 75-minute allocated for this subject. So what else?
Chair Khan, you have up until 9:50 to stay on track. And so we are scheduled to take a break at 9:50. So you still have about 33 minutes from my account.
Okay, perfect. So let's proceed. Micah, what else do you have?
Okay, so I want to summarize what I've heard so far on non-claims-based spending. It seems to me that you are all generally comfortable with these categories, and Teresa made a proposal to add public health spending, and I guess we'll come back to that at the next meeting, as well as any other input that comes in.
All right, thank you.
Okay, prescription drug rebates. I explained this in response to Flo's question. As I said, I think that there are strong advantages to doing this. Experience in other states shows that while these are confidential and can't really validate them, that insurers have been willing to provide aggregate pharmacy rebate amounts for purposes of doing these calculations. So I just want to see if anyone objects to the idea of including pharmacy rebates in the non-claims-based spending.
Any comments from any commissioner on that? If not, we can move on.
Okay, so our second category is member cost sharing. And Chair Khan, you talked about the how this is a significant part of total healthcare expenditures recently. So we're talking co-payments, deductibles, co-insurance. This does not include, as to the conversation we had much earlier, out-of-pocket spending for non-covered services, for non-healthcare services that are obtained through a discount offered by an insurer. It also doesn't include spending by individuals who are uninsured. And I added in here the why question. And the reason is not because this isn't legitimate spending, but because there's no systematic way of capturing such spending. I will say that hospitals tend to capture this. It varies by state in terms of whether they actually do it the same way. Sometimes it's left to individual hospital discretion, but other providers do not routinely capture this information. So other states haven't included healthcare spending by people who are uninsured, who certainly are spending money on healthcare services. There has been exploration in some other states on trying to develop estimates for what that spending is. In Connecticut, they're trying to access data through the FQ8Cs, which track this. And there's been some discussion in Oregon about ways to do supplemental reporting or estimates, but there's no systematic way to capture that information.
Okay.
Question on that. Can I ask a quick question? So when someone comes into an emergency room in our hospital and they are uninsured and they are treated, and there obviously is a cost associated with that, what bucket does it go into in terms of spend for the hospital or emergency room or even a provider? Is it just a charity care? I mean, how does that get reflected within the books?
So it doesn't, because we're looking at spending outflows of dollars to providers, not at costs assumed by providers. Okay, when we talk about spending, sometimes it has different connotations or costs of different connotations. We're talking about outflows of dollars to providers from payers and from consumers as part of cost sharing. Okay.
Thank you.
Yeah.
All right.
And I understand this is confusing.
All right, Mike, you may proceed.
When states measure performance against the benchmark, they have payers submit claims-based costs using what are called allowed amounts. So these are amounts that include the amount that the payer paid, say the insurer paid to a provider, plus any member associated cost sharing. The member cost sharing is not separately reported and separately analyzed, although you can do so out of an all payer claims database if you develop one. And in fact, Connecticut recently analyzed what was the per capita growth rate of out-of-pocket spending separate from total spending, and found out that it was in fact significantly higher than total spending. So the allowed amounts include what the members obligated to pay, but that doesn't mean that the member pays the obligated amount. We know that there is bad debt that providers incur when a member has coinsurance and deductible and they owe money to the provider and they don't make the payment. So this is an acknowledged limitation of this methodology in using allowed amounts. We know that not 100% of the allowed amount is received by providers. Okay, so with those limitations understood, my next question to you is, do you want to adopt patient cost sharing as part of your definition of total healthcare expenditures using this paid claims allowed amount approach?
So if I may sort of check a couple of providers I hear, one, the physician provider side, like to hear from Dr. Barron and Dr. Slonim from the hospital side. What are their thoughts on this question? Dr. Barron?
Yeah, I think it's important to include in the definition of cost sharing the spending that you just outlined. It was an important acknowledgement that you made, Michael, that the provider does not always collect on the obligation from after the service has been provided. And that's, I think, an important chunk to consider. That when you combine that with the deficit that's created in terms of providing a service for less than what it costs to provide that service, hospitals and physicians and other practitioners, those are two big portions of cost sharing that the provider is doing or the hospital is doing, that will not be accounted for in this benchmark process. And so I would just sort of put a pitch in that when we kind of conclude after all of this data collection, that we acknowledge that there's some significant deficits in what our data is going to show us. And when we try and set a benchmark based upon the information we will have, we need to understand that those are things that are not being accounted for in our collection of data.
Thanks, Dr. Barron. Dr. Slonim,
Yeah,
your thoughts as a hospital provider?
Nothing to add, Chair Khan. Thank you.
All right, Mike, you have comments?
So I'll note, if there are changes, significant changes in the percentage of payments of cost sharing obligations that are not met, that's more of an issue than if the percentage of the cost sharing obligations that are not met remain constant over time, because what we're looking at is not at per capita spending, but at per capita spending growth. And so I just want to make sure we all understand that that's what's most important, is the impact on growth.
All right, thank you. So we want to proceed.
Sure, and Chair Khan, if I may, for one moment, I just want to acknowledge that Mesa Van Helling, our Commissioner Van Helling, is now joining us.
All right.
Thank you, Sarah, and apologize, Chair Khan, for being tardy there.
No problem. So I don't know whether you heard the discussion on the provider side. Do you have any comments? We got it from Dr. Slonim.
No, I agree with Dr. Barron, and kind of back to Commissioner Khan's question on how do providers book and recognize the unreimbursed expenses or care provided typically in an emergency room setting, because that's typically where we see care provided for those that are underinsured or lack of insurance. So that typically goes, obviously we have a lot of programs that we try to qualify people, obviously, whether it's a work comp case or Medicaid, or we know that many private insurance plans have much higher deductibles. So we try to work with the patients to be able to set up payment arrangements, but that we do need to recognize that, since we're probably hovering around 9 to 10% uninsured currently in the state of Nevada. So I think that's an important part of the cost and also reimbursement that needs to be recognized, but also cost sharing with some of the higher deductibles and other plans. You've got primary insurance, secondary insurance. So just making sure that we capture that to give a full picture, Chair Khan, it would be important.
Thank you. All right, Mike, you want to continue?
Sure. So the last of the three elements of total healthcare expenditures is what's referred to as the net cost of private health insurance. What this is the spending associated with the administration of private health insurance. And it's simply stated the difference between the premiums earned and the benefits incurred. So this is administrative costs for private insurers. It's also insurer profits, or for a nonprofit insurer, something that's referred to as contribution to reserves. It also includes losses. And so the net cost of private health insurance for an insurer can swing a lot from year to year if an insurer goes from incurring losses to having a healthy margin the next year. All the other states that currently have cost growth benchmarks define and measure it the same way. They gather information from carriers for the self-insured market and through federal financial reporting forms that all commercial insurers complete. And then it's calculated for each commercial market segment within a state. And you can see them listed here.
All right.
Okay, this is pretty straightforward, I think. And so my question is, do you want to include the net cost of private health insurance in your total healthcare expenditures definition?
So let's go through the commissioners, if anybody has an observation. I may want to start if Commissioner Schoner is back on. If not, then we'll go through the sequence because he represents the managed care and payout side.
Okay.
If he's not, then we can proceed with anybody in order for question.
Commissioner Sean Shaner, are you there?
So he's probably, we have lost him, I think. So let's proceed with anybody else having questions in order that they raise their hands.
Okay. I don't see any commissioners with their hands raised at this moment.
Okay.
Commissioner Bohannon, hold on. Commissioner Bohannon just raised her hand.
Go ahead.
I had actually raised my hand for the last comment. I thought we were going around for each question. So for the last question, I wanted to be clear on some of the terminology that we're using, like deductibles, because I think there's some confusion sometimes in how insurers do the cost sharing with patients. And while there's deductible, there's also your max out of pocket, in network and out of network, and those can be substantially larger than your deductible. So I want us to make sure that we're very clear on that. And then also I was curious about, because there has been some discussion about the costs that are incurred by the provider. There are things called medical liens and lawsuits, which are pretty abundant. And so I'm curious if other states have included those at all, looking at the liens that are put against patients.
No, they're not included because they're, I think when they're applied because there's a cost sharing obligation that wasn't met, I think. And so to that extent, it's already been captured in the allowed spending amount.
All right. Do you have any additional question there? So Sarah, you
well,
want
I've just recently seen some, I kind of tried to research it here in Nevada, but there are some liens put against patients in the hospitals. I have to go and do the research. I don't know if they're allowed to do it here in Nevada, but I am kind of curious about how that can fit into it, because it's not always just because they can't pay. And so I am kind of curious about that, and just thinking about it, advocating for the patient standpoint, that there are oftentimes liens put up against patients that are through no fault of their own.
All right.
Great. I have Commissioner Sean Shaner.
Mr. Chair, this is Sean. I apologize. I heard my name. I was having technical difficulties. Was there a question that you had for me? Something you want me to comment?
Yeah. I think I have my senior moment that I'm entitled to, so I forgot what the question was. No, I think it was in reference to the payer. Mike, you remember what the question that I wanted Commissioner Schoner to chime in?
I think in general, you wanted input on inclusion of the net cost of private health insurance in the definition of total healthcare expenditures, since it's largely, well, not largely, it is about private insurer administrative costs and margin.
And there are administrative costs. I'm not sure exactly what the question.
So would you support or object to including in the definition of total healthcare expenditures payments made to insurers for administrative costs and profits or losses incurred by health insurance?
Part of when you build up a premium, part of it is administrative costs. That's part of it. We employ, as an example, case managers, nurses that work in Mason's hospital, Commissioner Van Houweling's hospital, UMC, to assist our patients and their case managers working on getting patients through the process. So definitely there are costs associated with employing those individuals. So I would say yes, those costs should be included in the total healthcare cost expenditures.
All right, so that's helpful. So Mike, you want to proceed?
Sure. So we're not going to get through all three of these today. I think that's clear, but let's see if we can get partway or all the way through number 2. So we've talked about how to define healthcare spending that will be measuring relative to the benchmark. Now the question is for whom? And so I've got a few questions I want to walk through here. I want to note that some of the populations of patients or members referred to as coverage groups, the ability to include them will depend on access to data. So on the left, you can see here the primary sources of healthcare coverage in any state. And these are the categories of coverage that define the population for which we're measuring spending. And every state includes all of these. Okay.
So what is the question you want the commissioners to answer?
I don't have a question yet.
Okay.
No question quite yet. What I want to note is there are other sources of healthcare coverage where states vary in terms of what they do. So some states capture data from the VA, some states capture it from their state correctional health system, and there's at least 1 or 2 states that are trying to obtain it from the Indian Health Service. I'll note I did not list TRICARE here. TRICARE is the health insurance program for the U.S. military, and that's because the commercial, the carrier that administers TRICARE is typically a licensed carrier within the state, and so it will be come in through commercial coverage. So too will state employee coverage come in under the commercial category because those are employed persons and dependents whose benefits are being administered by a commercial carrier within the state. Okay, so I would say the prior slide are the universal populations that are included, and these are the ones that are vary by state. So here are some pros and cons to those 3 that vary by state. You'll see that for all 3 of them, they represent a relatively small percentage of the population. VA, about a little less than 2% of state residents are covered by the VA or through TRICARE. State correctional health, that's about 0.7% of the population is incarcerated, and 0.9% of the state population self-identifies as American Indian or Alaska Native, but that doesn't mean that they are all served by the Indian Health Service. In fact, it's highly likely that they're not. It is possible, experience shows, to get data from the VA and from state correctional health systems. You can see the states that do so. The Indian Health Service, it's not quite clear if it's obtainable. Oregon has included it, and Washington recently decided that they wanted to as well, but I'm less sure about the ability to obtain spending for the Indian Health Service in a given state. Okay, so my question for you now is, which sources of coverage does the Patient Protection Commission want to include when measuring healthcare spending against the benchmark? And are there any other sources of coverage I haven't identified that you think we should include?
So I think, if I may sort of summarize it, you have Medicare fee-for-service and Medicare Advantage, which is a large chunk, and then Medicaid fee-for-service and managed care, which is also a pretty large chunk, at least in Nevada. And then you have commercial fully and self-insured, which is also significant. You already alluded to the fact that veterans and correctional service and Indian health are smaller. So the commissioners can give their opinion. I don't think there may be a major disagreement with considering the top 3. The question really then is whether we want to include the veterans, state correctional health system, and Indian Health Service. Is that a good summarization to focus on those bottom 3, whether the commissioners want to include those, because the others are pretty standard here and in other states?
That's correct.
So should we take opinion on those last 3 from each commissioner to see if they want to add those 3 or one of them or 2 of them in this data. So Sarah, you want to go through every commissioner's?
Sure, but we have Commissioner Van Halling who just had his hand raised. Did you want to speak first?
Oh, no, well, I'll
Okay.
just, it was on this subject. There was one that I thought maybe we should add, but I'll wait my turn. Sorry, Sarah.
Okay, all right, no problem. So do we want to start with Commissioner Flo Khan?
I'm not sure on this one as of yet. I guess I have a question with some of the outliers in terms of the states varying on the inclusion of these different sources. Is it just because some of the data is hard to obtain within the states? Is it because it would skew some of the other cost or the spending because of the nature of the population? Or I'm just more curious as how the inclusion of these will impact the broader kind of.
It's not going to impact total healthcare spending calculations a lot because these populations as a percentage of the total population are all very small.
Okay. Okay.
Right. Who's next, Sarah?
Commissioner Howard Barron?
I think another thing to consider in those bottom three, as you put it, is that there's also some constraints in healthcare costs and spending in the VA system and the correctional system and Indian Health Services that are sort of federally related that we don't really have much control over as a state. And so in addition to them being a small percentage of the total insured population in Nevada, there's also some cost constraints that are kind of set in place federally for those programs. And so, or at least for the VA and Indian Health Service. And so I'm not sure that we probably create more heartache and concern than we add to the data by including those three. So my thought would be to stick with the first three in your list and avoid trying to add those right now.
All right, thanks. Next, please.
Okay, Commissioner Jessica Flood.
Thank you. I thought that it would be interesting. So I guess to Commissioner Khan's point, if it's all just coming into an aggregate and we're trying to be more accurate by including that, I'm not sure we benefit from that. That's kind of what Commissioner Barron was saying as well. But I'm wondering if it's worth trying to track some of this stuff. I guess I work a lot with the criminal justice system, and in the state, there's a large movement for criminal justice diversion. The state also has issues with not providing enough healthcare to inmates. So I wonder if there's a way to pull it out, or if that would be an intended piece of this, to pull out like correctional health system and see their spending, or if that's like maybe I'm drifting off the function of this.
Mike?
Michael, go for that, Chair Khan.
Yeah, Mike, go ahead.
You could choose to track how correctional health spending is trending over time as a separate line in addition to melding it into the total.
All right. Next, Commissioner.
Commissioner Sean Shaner.
I'm perfectly fine including those last three in the total.
Oh, all right. Next.
Okay. Commissioner Tony Sonam.
Thank you. Yeah, I'm fine including as well. In particular, the state correctional health system has downflow responsibilities to big health systems, right? So when those patients have to be admitted from a correctional facility, it adds substantial cost to the way we have to deliver care, and it's not compensated well. So I'd like to include it and see what's going on.
All right, next, Commissioner.
Commissioner Mason Van Howling.
Thank you, Sarah. Yeah, I think the last three, obviously we are a big destination for military, retired military, since we have Nellis Air Force Base, but also just a destination for warmer weather. I think the other last two are probably very small numbers, but I did have a question for Mike. We do, and one of the earlier conversations this committee had was promoting our exchanges, through Nevada Health Link, and a program that we really need to continue to grow in our state to make insurance affordable and access. But I guess the question is, would that fall under one of the top three categories, or is that, I would just hate to miss the exchange.
That would be in commercial.
Okay, commercial. Okay, so then I'm good with the list, and It's just data, so we can probably slice and dice the information if we want to carve out IHS and corrections. But the VA is a relatively large number that that we do see in the community and growing.
All right, the next commissioner.
Commissioner Teresa Bohannon.
I would fully support including the last three. I think they fall under special populations and sometimes have unique health needs. The one suggestion I have is access to healthcare network. It is up here in the north, and it would help us capture some people who cannot afford commercial health insurance. I'm looking at their website, and it looks like they are covering about 27,000 clients right now. While that might be a small number, I think it can give us some good insight into people who cannot afford traditional insurance.
All right, thank you. Next commissioner.
Commissioner Yarleni Roadugan.
I would like to add all the sources, especially the minority sources.
All right. Anybody left still?
You, Chair Khan.
Yeah, so if I hear everybody correctly, I think the majority of the commissioners would like to include the last three in it. Is that a correct assessment? Anybody disagrees with that? Because it sounds like the majority would like to see that data also. And I have no problem with that. I mean, the team from Mike, they can collect that data. My only comment is on the Veterans Health Administration. Keep in mind, the veterans system, for example, in this state and other states, one component of it is delivered at the VA system itself. But there is also the patient choice program where they are allowed to go to the doctors and hospitals in the community under circumstances A, B, C, and D. So that gets the cost into the community, which is then reimbursed by the VA system. So that's another significant element, that the community is taking the burden of providing that service, which the VA is not because they don't necessarily have it, but because the patient has the option. I think it's still the 30-mile zone. It was supposed to be changed. I don't think it has been changed. But that's the other component of the veterans services that go out in the community. But that's my only other comment.
Chair Khan, I just have a quick clarifying question. So it sounds like with the operating principles we adopted, we need to have consensus. And Commissioner Barron I think he was not as supportive of this, but it didn't sound like he was passionate in that distance. So I just wanted to make sure, are we trying to get consensus, and is Commissioner Barron okay with it, et cetera?
So Commissioner Barron, let's hear whether you have passion or not.
I have no passion. No, thank you for acknowledging that, Jessica. The reason I had sort of suggested against including those was not because I wouldn't love to, in an ideal world, include all of them. It was just more Michael's presentation of the fact that the VA system collects data in a way that would be a little bit difficult to interpret, and that the other two, it would be, my impression from him was that it would be virtually impossible to gather the data accurately, and to be a significant inclusion in our work. So that was really my basis for saying not to include the bottom three. But I have no problem if it's practical to include them. I have no problem in offering my consenting opinion of including them.
All right, thanks, Howard. So did we miss anybody right now? Commissioner Flood, does that answer your question?
Yeah, thank you.
All right.
Really quick, Chair Khan, Commissioner Teresa Bohannon brought up the point of Access Nevada, and I'm not sure just if she wants to make sure that that's included, if we can get consensus with that, and maybe lean. I think we have, I don't know if we don't have Director Whitley on here. I just wanted to know if we wanted to also talk about that.
So any comments?
I just have a question. Michael, you mentioned that you could track kind of some of these individually kind of outside of the kind of benchmarking, but we could then follow kind of the spending within these. Is that a better way, like to kind of keep them separate and just have, but collect and as to the extent that is practical or possible, and then do a tracking of the spending, but not have it included within the total healthcare spending cost of the benchmarking project? Or how would that work?
Generally the approach is you measure performance at the state level. So you add all the categories together, then you measure it by market. So these, the top three represent the big markets, but you could do the bottom three separately as markets. They're not really markets, but as markets. And then at the next level, you probably wouldn't take these down, but you might then look at individual insurers for commercial Medicare or Medicaid, and for large provider entities, commercial Medicare, Medicaid. You wouldn't break those three down that way because it's not applicable. So you'd only include them at the state level, and you could track them at the market level.
That's right.
Chair Khan, sorry, you're on mute.
Sorry, so how are we doing with time, Sarah?
We have 10 minutes.
All right, and Mike, how much more information do you have, or are you done?
No, I have a lot more, but I think I can get a little more done in 10 minutes.
Okay, because we have a question and answer time, and my understanding from Sarah is you thought 75 minutes was more than enough.
Well, it turns out it will not be. You are all a very engaged commission. I applaud you for that, but it means we didn't get quite as far as I thought.
So the reason I say that, because our next item on the agenda could be probably also significant in terms of time. But anyway, if you can summarize whatever you can, and maybe the commissioners, unless it's a compelling question, can get the answers offline, and then we can discuss them at the next meeting.
Yeah, some of it we can push to the next meeting. I think we did quite well today, but there's a little bit more. Let me see if I can squeeze it in our remaining time. Okay, so the next question is what should be the residence of the individuals for whom we're calculating spending, and where should the location of the providers be? So there are four options here. I think it's pretty obvious that we want to include state residents who receive care in state. I think it's also pretty obvious we want to exclude people who don't live in the state who receive care out of the state. So that's two of the four boxes. It's the other two boxes I want to ask you about. So the first one is receiving care from out-of-state providers. So state residents get their care out of state when they're traveling or temporarily living out of state, or they live on the border and they seek care across the border. The 5 other states include spending for state residents who receive care from out-of-state providers when calculating spending. Okay.
So we need to get the opinion on this item, at least from the commissioners. The answer would be yes or no to include that or not to include that. So if we can do that, that might help moving to our next point. Or do you want to take them collectively, Mike?
No, let's ask right now whether you think we should include spending incurred for state residents, but with out-of-state providers.
Okay, let's go with every commissioner, unless only 1 or 2 have a question, then we can bypass our process.
It might be. I think this is an easy one, so you might just ask whether anyone objects to including.
Right. That's what my thought was. I was about to say that. Great. So anybody objects to that, to include out of state? My personal thought is that could be a significant amount. People go out of network. Managed care has to pay a significant amount for out of network services, other than the emergency services, et cetera. And those in the border areas go back and forth between Arizona and here. And there's a large chunk of people coming into the state from Arizona, next door to smaller towns. So yes, I think that's personally, I think it should be included. Anybody has any objections? Otherwise, we can move to the next item. All right, let's proceed, Mike.
Okay, so last question of the day. Should we include spending on care for non-state residents who receive care in state? So this one's been debated a little bit in some other states because often there are state employees, there are other workers who commute into the state for work and receive their health care in the state. And that's spending that's an expense for state employers. We could only capture this from insurers that are required to report, which would be licensed insurers in the state. If there's insurer license out of the state, we wouldn't be able to capture that. There's also a general question, do we really care about spending if it's not spending on behalf of state residents? The other states debated this, and some of them quite a bit, some not so much. In the end, they all decided not to include spending for non-state residents, even if they receive state care in state. So
okay,
this is my last question for you for today.
So the same way, does anybody have reason to say to include this?
Commissioner Bohannon has her hand raised.
I guess, Mike, I have like two concerns about this. Like, one, we're such a tourist heavy state. So I see, do we include people who come here, they're visiting, they get in an accident and they're at UMC? Or are we talking about people who maybe live in border areas and they're coming to either, Reno from Tahoe or, in Southern Nevada because there's specialty care? I would be more interested in those people and not necessarily tourists that are in the area. So I could go either way, but I think we kind of have a unique situation because of our tourist industry.
Do you have any answer to that, Mike?
Well, I mean, so you have people from out of state that generate a significant amount of healthcare in your state because of tourism. The question is, a broader philosophical one. Do you care about that spending? Because that spending is being done by residents of other states and insurers in other states and employers in other states. So it's not Nevada spending. It is Nevada healthcare services, but it's not Nevada spending. So that's the question that I think you need to answer. I'm not going to tell you what the answer should be. You all should decide that, but that's the question.
All right. Anybody else has any thoughts? We're getting close to 9:50 unless you guys want to skip the break.
Sirkan, we've got a couple of hands raised, but if you want to go back to, I think it was Dr. Barron, Commissioner Dr. Barron, was he? Yeah.
Yeah, thank you. Thank you. Yeah, I mean, I would agree with Teresa that we have a unique situation because of the tourism. There's even, certainly there's been a lot of talk over the last 5 to 10 years about trying to make, at least in Southern Nevada, medical tourism becomes a significant contributor to economic diversity in our state. And I think even though it is not spending within our state from insurers that are within our state, to some degree, the cost is still being incurred by providers and by hospitals and so forth. And so I think that that's a significant thing, and I would like to see us buck the trend from other states and include it. That's my 2 cents.
Who's the next one, Sarah?
Looks like Commissioner Yarleni Roa-Dugan, and then we'll go to Dr. Slonim.
Yes, so this is Yarleni Roa-Dugan for the record. My question is, working as a nurse, I see a lot of patients come in to the hospital that are from California or other states, and they have lost their insurance and they come in, and so where would they fall in? Would that they still don't have Medicaid coverage, or they may be applying for emergency Medicaid? So where would they fall in? Because that would incur into our state's expenditure, I think. I don't know.
So if they get Medicaid coverage, they would be covered. We would include that spending. If they're not covered and they are essentially uninsured, then we're not capturing that because there's no payment to the provider that's being made except potentially by that individual. And then we don't have any means to collect that spending data.
All right, who's the next commissioner?
Commissioner Dr. Slonim?
Thank you, Sarah. Tony Slonim. I agree that we should include out-of-state residents. Up here in the north, we're so close to Tahoe that a lot of those patients who live just over the border are coming in, and I think that's important for us to capture. The other thing is, for me, Michael, is that bottom right quadrant, the out-of-state resident, out-of-state provider. Aside from my dear colleague, Commissioner Van Houweling, there are no other transplant centers in the state. And so all high-end, high-resource utilization care goes out of state. Heart transplants, bone marrow transplant, all of those kinds of high-end procedures. And not capturing those, I think, is an important shortfall in understanding just how much care we're paying for.
Well, that would be in the top right box, not the bottom right box. So that would be a state resident who's going out of state.
Thank you. Yep.
So why don't we do this? We are at 9:50. For consensus sake, is there anyone amongst the commissioners who's opposed to including those three items? Anybody?
I don't see any hands raised.
Okay, so it looks like we have a consensus to include those items, and you can decipher how to best do that later on and share it with us.
Okay, so we'll document that. I just want to make sure, though, that you all understand that if we include the out-of-state residents receiving care in-state, we'll be limited to getting that information from carriers who are willing to provide it. So someone who's covered by, I'll just make this up, Blue Cross Blue Shield of Florida and comes to Nevada and receives services, we're probably not going to get that spending data. Okay, we probably will get it from the Nevada carriers who are covering people in bordering states.
So why, if I may say, why don't we just see whatever we can get? That's the bottom line. We can't get it. So whatever we can get it, that would be very helpful.
Okay, good.
Right. So are we done with your presentation, Mike?
Well, I think we've gone as far as time will allow, and we nearly got through it all. So I feel very good about it.
Okay, thank you. So we have a break time for 10 minutes. So it's 9:52. We'll regroup at 10 a.m. if it's okay with everybody. All right, so we regroup at 10 a.m.
Chair Khan, can you hear me?
Yes, I can.
Okay, great.
So it's 10 o'clock. Let's make sure everybody is back. Do we have everybody back?
I believe we do, but commissioners, if you can turn your camera on so we know that you're back, that'd be helpful.
Are we okay?
Chair Khan, it looks like we're just waiting on 2 commissioners.
Give them a minute.
Yeah, we have Commissioner Van Houweling and Commissioner Sean Shaner. Can you just let us know that you're back?
And I'm here, Sarah Darlene.
Thank you. Commissioner Van Houweling and Commissioner Sean Shaner, are you back?
So it's 10:01. So I think let's start.
Okay.
Our quorum was already established in the morning, so we are okay with that, quorum wise. So our next item on the agenda for possible action is the discussion on creating new or making changes to the existing committees, including but not limited to establishment of scope, jurisdiction, appointment of members from PPC or attached list of possible members, designation of a chair, etc., assignment of scope and duties. So on this item, my opening comment really is that today we'll start the discussion. This could be quite a long discussion, as we all know. So what I would like to do as chair is we need to today start the process to define and deliberate scope and purpose and membership of committees moving forward. So if we can do that, and the deliberation, the defining the scope and purpose, and then also the membership on the committees, then we can move forward. We may not be able to do it today. If not, then we may have to defer the action and carry on at the next committee meeting. So to start the discussion, we in the past have had general sort of discussion on top 3 as defined in the agenda: healthcare cost subcommittee, Medicaid subcommittee, network adequacy subcommittees. These have been discussed in a general manner in the past at one of our meetings or a couple of meetings. And then the potential new subcommittees that came through from solicitation of the group was the workforce development, quality and advocacy, stakeholder advisory committee to the PPC for the Peterson Millbank program for sustainable healthcare costs. So these are the additional ones that have income, because Millbank's discussion came in only in the last couple of months. So this was not a discussion in the past. So having said that, before we open up in an orderly manner to start proceeding with this, we did receive in writing some comments from Commissioner Babette Bond. So we will have to read that into our record. So that becomes a part of the record, as we discussed earlier today. So Sarah, you may want to please read that. It's not a very long sheet anyway.
No, actually, Leslie, if you can, I think Leslie has it up and she'll read it into the record accordingly. Thank you, Chair.
Okay, this came from Commissioner Babette Bond. Pardon my absence for part or all of the upcoming committee meeting scheduled for tomorrow, 4/21. I have a dental emergency and cannot attend on time. In my absence, I hope this communication can serve as a placeholder for future discussions about the topics being discussed today. Regarding the Millbank Advisory Committee, first, I would appreciate consideration of a problem that may exist with the advisory committee appointment process itemized for consideration tomorrow. I'm not aware of a process for public input or a public application for this committee. if only members of the Patient Protection Commission have been included in soliciting potential committee members, I would request that we create an additional step or steps that allow opportunity for interest by those outside the commission. For example, the name I submitted for this advisory committee is not included in the material submitted today, so we'll be unable to be selected. Regarding other committees, the appointment process for the other committees previously created by the PPC in our second meeting does not seem to be transparent or comprehensive, and I would ask that this process be revised and consideration made of the following. The potential committee structure and scope of the committees approved in the second meeting of the PPC should be determined prior to soliciting names for these committees. I request consideration by the Commission of a process to determine the number of committees the Commission staff have resources to manage, the scope to consider for each committee, the size, structure, and leadership considerations of the committee, the intended goals, and the time frame for the committee. When the 3 committees were approved at our second meeting, they were never created. The work was not completed because there was concern that the commission support did not have the capacity to manage 3 committees. How has that been resolved? Our second thought on this was, once an understanding of the purpose and structure of the committee is established, the commission could then be in a better position to consider a committee membership process. Boards and commissions usually have a public process that allows those interested and invested an opportunity to apply, followed by a clear process for selecting candidates. Applicant criteria for consideration. Because this commission is a statewide body with a primary mission of protecting patients, the committee should be tasked with supporting this mission. Our commission can benefit from committee composition that creates a voice for the advocates and patients that are not on the commission. Number 1, commissioners should have an opportunity to determine if a limited number of recommendations for appointment can be submitted by each commissioner. 1 member of a 10-member committee should not provide a disproportionate share of the names on a list for consideration if the intent of the committee work is balance. The purpose of our commission should guide the committee work, and the commissioner should have an opportunity to carefully consider the role of committee members. For example, should subcommittees provide expertise that is missing on the commission rather than recreating the same expertise in the committees that we have on the commission? Or should we instead seek support from perspectives not present on the commission? Suggestions for how to move forward include, do we have adequate representation from patients, the charge of this commission? Do we have adequate representation of the diversity that exists in the patient population in this state that will allow us to adequately understand the role that racial inequality and social determinants of health play in patient experience and state health care structure? Why would we appoint any committee member who has resigned from the commission? What expertise is needed from the healthcare industry lobbyists? Their positions will, by job duty, reflect those of the industry already respected on the commission. Already represented on the commission. I hope the commissioners can consider these and other issues before we complete the Millbank Advisory Committee creation and before appointing members to the committees previously approved by the commission. I would also hope that we will not consider additional committees at this time, some of which may already exist in the state. Thank you for these considerations, and I look forward to attending at least a portion of the meeting tomorrow. That's it.
Thank you. That will be included in our record, the presentation. So as I said in my opening statement, so we need to actually start the process actually, and I would underline the process because we haven't established any of that yet, even about the committees we talked about before. So unless we develop a proper process and deliberate and define the purpose of each subcommittee, obviously we cannot move forward with taking action on that because we have no structure established by a majority of the commissioners on each subcommittee. So my question, first one is, we have talked about 3 subcommittees before, so it's a part of our record in a public meeting. And then we have since had Millbank come in, and we are advised by the governor's office to, focus on that also. So my first question is, should we, given the governor's directions, also consider first the process, purpose of membership, etc., for the stakeholder advisory committee to the PPC for the Peterson Millbank program as number 1, and then go on to the other 3 committees that we have discussed before and others. Obviously, this will not be accomplished today in the next couple of hours, but at least we'll be able to define how we go about doing this, how we define their scope, et cetera, et cetera. So that is my thought on moving forward. So first, I would like to have the opinion of the commission members to agree or disagree with taking up the advisory committee for the Millbank project that we were advised by the governor's office to take on, and see how we define the scope, process, et cetera, of that committee, and then go on with the others, and however many we are hopefully able to complete today, we will. Otherwise, we'll defer for action at our next meeting. So maybe.
Chair Khan, if I may I make a disclosure before you solicit their feedback?
Okay.
So commissioners, I just want to make a disclosure about the collection and the solicitation of the names. I want to make sure that everyone has the same equal opportunity. And first, I want to acknowledge one thing publicly. And as Commissioner Babette Bond indicated on her statement, one of her recommendations was inadvertently left off of the attached agenda item and could not be included because of our open meeting law requirements, because it was after the deadline. So that was not intentional. That was just a mistake on my part. I missed one of her names, and so that is entirely my fault. In addition to that, I did get some feedback from another commissioner, Commissioner Teresa Bohannon, who indicated that it wasn't clear to her that we were soliciting additional names. And so she does not have any recommendations on this. And so should the commission consider moving forward with this advisory subcommittee creation, I do want to acknowledge that those names are missing, and perhaps you could, you have plenty of options. You could consider adding additional names at the next meeting or at an additional meeting, but I at least wanted to put those disclosures on the record before you opened up your discussion.
So those names are available today for this open meeting that were missed?
I'm sorry?
The names that were missed, are they are available to every commissioner today as a part of our open meeting?
No, Attorney Ott can opine on that, but they can be included in the discussion, Attorney Ott, but I don't believe that they can be considered in any action. So anyone that Commissioner Bohannon may mention today could be added in a discussion, but would have to be properly agendized at a next meeting to be included in the action. Same thing for Commissioner Babette Bond's omitted recommendation.
Which is fine. So my only thought on that is that by the time we end up defining the scope and the process, et cetera, on the committee, we may barely be able to get to the membership today as to who gets into, who should or should not be on the committees. We've had a very robust list shared by everybody that came to us. If I'm not mistaken, Sarah, the last I know was 51 names.
Yes.
Collectively, correct? So
Correct.
We have a very robust list to choose from once we define the process of how we choose and how, as I said earlier, I'm repeating myself, the scope and purpose, et cetera, of each committee. So going back to my previous question on Millbank, is everybody in agreement or not that we should consider that as number 1 today, or start deliberating on that, since that's a priority of the governor? Anybody opposed to that? We'll start deliberating on the scope, purpose, etc. of that committee, and if possible, if we have time, to go to the membership of that committee today, and then look for action. Anybody opposed? If not, then let's start with that process. So I personally would defer any thoughts of mine on that committee. Sarah, you want to give us a little synopsis on the concept of this committee that would help Millbank, and how are they anticipating that committee to be of value to them?
Yes, and so if I can, thank you, Chair Khan. We've got Michael Baylitz on the line with us, and he can further outline the benefits that he has seen in other states with this advisory subcommittee. But the purpose of this subcommittee is really to solicit feedback in between the PPC meetings with non-PPC members that would receive the same presentation you received, and Mr. Baylett and his team would take their feedback and report it back to the commission at the next meeting for your consideration. Michael, would you like to explain how this benefits other states?
So before you go, Michael, if you could kindly, not just other states, what exactly has been the scope and purpose defined for this committee elsewhere that brought value, and what value did it bring to you, and what kind of membership was helpful to you in other states, so that when we are looking at membership, we focus on those who bring value to you from advice that other states have chosen. So at least there's at least some starting baseline for us to deliberate on.
Mm-hmm. So I think the value it delivers actually is to the commission more than it is to me. Creating a body of stakeholders who are outside of the commission allows you to hear voices and perspectives beyond your own. And some of those voices and perspectives will be from individuals and organizations that obviously aren't represented here, but that will in some way directly or indirectly be impacted by the cost growth benchmark. And so by hearing those voices, you will hear perspectives that might not emerge from your own deliberations. In addition, I think having such a body increases awareness about this work, and that awareness and understanding helps foster participation and acceptance, and hopefully even support of the work from having broadened the conversation. So as Sarah indicated, we would propose that we would take the content from your meeting, probably condensed a little bit, and bring it to that body. We would tell them where you landed on a preliminary basis and ask them to react. And then we would come back to you and say, here are some key messages that we heard from the advisory body. It would then be your decision whether you want to incorporate any changes or not, but you at least would be informed by these additional voices.
So is it possible then to get from you by definition in a written format about the scope and purpose as has been defined elsewhere in the country of this committee? You've generalized what you've just mentioned, the gist of it basically. And then what kind of membership has been of value elsewhere? Now you mentioned membership from people who are not represented on this commission. Now, as you know, this commission has fairly broad representation already from various diverse backgrounds of people. So whether duplication of that is all right, I mean, I have no opinion on that, or you want somebody, like you said, not quote unquote, not represented on this commission. What is your thought on that?
Yeah, so I think some of the people might be an amplification of some voices that you already have. So you could include, for example, large medical groups or IPAs that might be measured under the benchmark program to hear their perspective. I think hearing from a couple of additional insurers, including maybe a Medicaid managed care plan, would be helpful. I think hearing employer purchaser voices is important. And I think hearing additional consumer voices is important. I think those four stakeholders give some balanced input. It is also sometimes the case that states will include economists or health policy experts who might bring some specialty technical knowledge as well.
Okay, that's very helpful. I think what I would like to do is proceed with every commissioner's input and thought process on what Mike has just summarized and what they have done elsewhere, etc. So Sarah, could you please make sure everybody is covered in their input? You can start the question process or
Sure.
opinion.
Thank you, Chair Khan. Let's keep to the same list. So we'll start with Commissioner Flo Khan.
Michael, I just have a question in terms of some of the other advisory committees that have been established in the states. How large are there? Are we looking at, from our perspective, putting forward to Commissioner Khan's kind of point about trying to identify these different groups that may be not represented on this commission? Are we looking to have each commission member, or in your previous roles, each commission member put forward one name? Are we looking at a limited number? I mean, what's been helpful? I mean, too many gets to be very difficult, but you want to have the knowledge from all the entities that's going to help guide the commission in terms of its work and deliberation.
Right.
So I think that's a very good observation and question, basically, of approximate numbers elsewhere, because if it's too big, it becomes, very difficult to function. So what is your experience? That's a very good question. Elsewhere, approximate numbers. We don't have to have those exact numbers. That give us some baseline to start off.
I think these groups can be a little bit larger because you're not asking them to come to a group agreement. You're just asking them to give feedback, and they don't have to agree. They might have differing perspectives. So, I think a group of 15 to 20 is okay for this purpose. I wouldn't want to have a group of 20 people to develop recommendations, but that's not their intended goal.
So how would you bring it to the commission if 20 people give 20 opinions on a subject? So we have to go through each opinion in our deliberation?
Yeah, in my experience, that doesn't really happen.
Okay.
That usually you'll get on a given question, you might get 2 or 3 opinions.
Okay.
People will repeat them.
So I don't want to take away the time from the commissioners to opine on this. So let's go back, Sarah, to the opinions of each commissioner.
Well, can I ask one more really quickly, Sarah?
Yep.
So on that, Michael, too, in terms of technical expertise, are we looking, obviously you could have patient groups that come in, like you said, and give kind of thought process, but what about also the technical expertise of knowing, as you're developing this benchmark, kind of the things that they're going to have to look for to actually, from a mechanic standpoint, that this could work? So is that another thing that you've seen in previous advisory committees?
Yeah, it's a good question. There's so little experience doing this that there aren't people who have technical expertise on how best to do it. So that's my honest answer.
If I may add, request the commissioners, as they're giving their opinion, please also opine on Mike's thoughts whether to consider IPAs, Medicaid, managed Medicaid, employer providers, consumer voice. So please give your opinions on those also, whether you are in agreement with some of those to be added or not. So please, let's continue the questioning.
Okay, thank you, Sarah. That's all I had in terms at this point.
Okay, thank you. Next in line.
Okay, and Chair Khan, just for a moment of clarity to maybe for all the commissioners to opine on a recommended structure at the end of the discussion, and ultimately it's going to be at your discretion to recommend a proper structure on how you would like to finalize and form the commission's desire to create this subcommittee, to include what Commissioner Flo Khan mentioned about how you want to solicit the amount of recommendations per commissioner. So I think that if it pleases the commission, and if you're okay with it, I would like to offer suggesting that the commissioners include a recommended structure in your thoughts when we go to you, so you can make a decision accordingly.
All right, thank you. Let's proceed and continue.
Okay, Commissioner Howard Barron.
So to that end, what Sarah just said, I would recommend that maybe for any of these subcommittees that the chair appoint one of the commissioners to sort of be a lead for the subcommittees, and because there's going to be a lot of people ultimately that are not commissioners, are not voting members of this commission, that will serve on this. And to herd the cats, so to speak, it might be nice to have one of the commissioners that's involved in each of these subcommittees. To that end, also, I put forth a few names for workforce development subcommittee, but did not consider people outside of that realm.
So Commissioner Barron, if we can, I think we're just sticking to the Peterson-Milbank topic for the first one.
Yeah. No, I understand. But I was just going to comment that to the extent that you mentioned that some commissioners didn't have an opportunity to put forth names and things like that. Once we define this commission, Peterson-Milbank subcommittee, et cetera, the other names might pop into our conscious stream of consciousness that we want to formally put forth. And so I would maybe suggest to the group that we hold off on assigning specific names to this or other subcommittees until everybody's had a chance to put forth names, understanding what the subcommittees are, so that other names, or other contexts that we may have, or as Bobette mentioned in her letter to the group today, maybe there's people from the public that wouldn't normally be in our stream of consciousness that would want an opportunity to apply to be on one of these subcommittees, and we should give people the opportunity. So that was my comment there. With regard to this particular group, I didn't hear Michael mention specifically, besides the IPA large group kind of a thing, I didn't really hear him say anything about providers or hospital representation on this particular advisory committee. And I'm just wondering whether it might be good to flesh out some providership membership on this subcommittee as well. So either from the Hospital Association or from the State Medical Association, or just somebody that might be able to provide some of that provider expertise. So that would be my input. I don't have a specific name in mind. I'm just throwing that out there as a potential benefit to the working group.
Thank you. Next.
Commissioner Jessica Flood.
Great, thank you. Okay, so my comments are, I think for this subcommittee, it'd be great to not recreate the wheel. If Baylit has already seen these subcommittees work in other states, I wonder if he could perhaps present, like in writing, the purpose, objective, just like he did with the operating principles for our review at the next meeting, as opposed to us really trying to work through that. So that was just one thought. The other one is, I think when we start trying to veto each other's recommendations, that's when it gets kind of messy. And so I was wondering, if it's supposed to be 20 to 25, if we have 9 voting members, is that correct?
10
voting members. So each of us gets 2 that we can recommend. And I really like Commissioner Bond's idea of also having an open process for people to apply and the commission to review as well. I don't have an issue like she does in terms of having lobbyists or other special interest groups involved. I think that special interest groups are impacted by this. And I really believe in diverse collaboration. So having them at the table now is more important than trying to exclude them and then having to work on it on the end. So those were my thoughts.
Thank you. Next, the Commissioner.
Okay, Commissioner Sean Shaner.
Thank you. I agree with Commissioner Flood there in terms of looking to Michael to make some recommendations as to what's worked in other states and the makeup of those advisory panels. I just want to make sure that anybody we put up is actually interested and will show up. So I know that some of the names might have just been thrown out there. So the application process, or at least confirming that they have the time to participate. The one thing, Michael, that I didn't hear you mention that I'm sure is covered off on, but would be just somebody from a behavioral health standpoint. I understand the IPA, the medical provider, Medicaid, MCO, et cetera, but just making sure that somebody's on there. Agree with Commissioner Flood. Generally, what's worked in other states, let's not recreate everything.
Thanks. Next, Commissioner.
We've got Commissioner Tony Sonam.
Thank you, Sarah. So as it relates to the advisory committee that we're talking about, it seems to me that that may be a little bit different in structure than the subcommittees that we're chartered to accomplish. So when I hear an advisory committee of 20-25 members, that's not how we've previously considered subcommittee work. And so I'm always want to make sure also, Sarah, that we have staff capacity to appropriately manage the different things that we have going on. For the advisory committee, again, it seems structurally different, and I'm not sure that it should be included as a subcommittee among the six that we've previously gone to bat with. In addition, I would say, and for all of us, this was an item that was agendized as a decision item. Going back to Sarah's email on the 9th to all commissioners, where she gave her an update and the list of what was coming up, this was agendized as I'm preparing a list and have your responses no later than April 14th, Wednesday, April 14th, so that we can vote on commission members. So we got what we asked for in terms of the ask of commissioners in terms of creating the agenda. I suppose we can change the agenda, but it seems to me a little bit off from a process perspective, because we came out and we said, you got to get it in. And previously when we've done this, there's been a hard stop. You got to get it in. I have no problem adding if people haven't submitted, but I think that for those that have submitted in an appropriate way, we should consider the submission because it followed the directions of the executive director.
Sarah, you want to answer that?
Sure. No, I really appreciate that, Dr. Slonim. And just for clarity, the way the agenda item was created was based on, during the last PPC meeting, there was a non-action item to discuss the possibility of subcommittees as requested by Commissioner Bohannon. And then there was separately a discussion about the creation of an advisory stakeholder group during Mr. Bailiff's presentation. But based on the discussions at your last meeting, it was very clear that this commission wanted the opportunity, and the key word is wanted the opportunity to consider action. And so when that was the direction, we needed to try to accommodate that request based on our open meeting law guidance. And so it was drafted in a way to make it legally permissible and allowable because you wanted the opportunity to consider action. It is not indicative necessarily of the commission's intent to create action. And I think that there is some confusion there. So I just wanted to make sure that, the discretion is still at the entire commission's option. And then also I would defer to Chair Conan on what he would want to do as far as structure. But the agenda item was really presented in a way, Dr. Slonim, to allow for it to be permissible, but it was not indicative of any desired action. And this was just a follow-up from your request during your last meeting.
Sure. I think the only other thing I would say is, so in following the approach laid out for our work, we now have in public record a list of people who have put their hands up. It's now on public record. And so for us to come back and disenfranchise people who have been put forth and who have had personal conversations with, they agree to do the work and put the energy into it, and to put that on hold with their nomination seems to me to be a little bit as disenfranchising as enfranchising in the conversation.
So if I may, Dr. Slonim, the way it is set up right now is, first of all, the names were solicited, which is one step in it. And the names are solicited with the fact that if the commission chose to appoint them, would they be willing to serve? The commissioners, obviously, we don't have the right individually to say, would you serve? And they say yes, so we have to do it unless the commission as a whole agrees to the names that were submitted by different commissioners. So that's number one. Number two, on the committee, obviously, to take an actionable item, we have to first, as I said earlier in the opening remarks, develop the purpose, scope, et cetera, before we even go to the names. We cannot have nominations of names to the committee without knowing what they're going to serve on and what is the purpose of that committee that they may or may not want to serve. Number two, we have several committees we are talking about. As of right now, we're talking about Millbank because the governor's priority. And then we'll come to the others as time permits, if not today, the next time. So as we progress, the 51 names that came in are not necessarily all to be considered for Millbank, which is under consideration today. Some of them may want to serve on other committees, and the commission can collectively decide, yes, okay, we agree on this name, and that's fine. And then we can also collectively decide how many names each commissioner could submit for each committee. For example, on Millbank, one can decide, that's why I asked Mike that question, generally how many people seem like reasonable. And he said, for this particular case, 20 is okay because we're just soliciting their opinion and they're not necessarily voting amongst themselves to come up with a consensus and give it to us. So each committee's purpose and process would have to be defined by us. And then we have to decide how many names each commissioner can submit for that particular subcommittee and how many members we would want to have to begin with on each subcommittee, and then go back to the people who have expressed an interest. For example, somebody may not want to be on a workforce committee that has submitted the name, maybe on another committee. So I think we just started the process today to narrow down the whole purpose of the committees, their objectives, etc. Then decide how many members each commissioner can submit. There's more leverage, I guess, if everybody wants 20 people, for example, hypothetically right now, then we have to decide whether each commissioner, there are 10 of us, each one of us gives 2. If we decide for another committee, we want only 10 people, then each commissioner would have the opportunity to submit one name that may be apropos for that particular subject on the committee. So I think that's the process we are following. And the names were submitted so that everybody is aware in a public meeting that these names are on our docket, if I may, for consideration for at least today, for the Millbank.
Just to clarify, so I was under the impression that the names I submitted were specifically for the Millbank committee. I understood what the function of the committee was, and I was told to make sure that they were willing to serve. So when I submitted my 2 names, I kind of had it geared for exactly that decision.
Which is fine. So we'll come to it when we deliberate, on the membership and the names. So if your 2 names are on that and we decide on 20 people, then those 2 names would be certainly, considered. And if we decide on 10 people, then it'll become one of those 2, I guess, if that's how we want to go. So let's go.
Just for the record,
Yeah.
go ahead, Tiff.
Oh, I just wanted to say, I'm worried about this slowing down. I mean, this seemed like a pretty simple process.
Yep.
Mr. Bailey gave us a timeline of what this is supposed to look with the stakeholder group established and the conversation going back and forth. And I worry that we're just going to push this down the road about the small minutia here.
No, yes, I mean, I agree with you to an extent. I would like to move this forward today, at least get over the Millbank part of it on the specifics that we are kind of elaborating, and continue the discussion at the next meeting for the other subcommittees as we have processed. Unfortunately, we have to do this first because of the governor's priority. Otherwise, we would have discussed the other committees today if we have, by 12 o'clock, if we have time for them. So I think if we focus on the structure, et cetera, on this one, and in future, we can talk about at the next meeting. So let's have the next commissioner's opinion.
Sure. And Chair Khan, just for a point of clarification, if I may, on the solicitation of names in the advisory committee. So there was no restriction placed on any commissioner who wanted to submit multiple names for whatever purpose they wanted on the agenda item. There were several commissioners who may have only submitted names for the Peterson advisory group. All of the names that were solicited, there was a requirement that I placed on everyone equally, that I at least needed confirmation that any of their recommendations, that person was aware that their name was, one, going to be placed on the agenda for consideration, and that they confirmed to that commissioner their willingness to serve. And so that is reflected accurately, I believe, on the attached list. Any commissioner that doesn't agree with that statement, please speak up. But I just wanted to make sure that that was outlined for your discussions. I know we are only talking about the creation of the advisory subcommittee, and yes, that was the intent of the original solicitation of the names, was for Justice Advisory Subcommittee, because it is designed to be non-commission members, non-PPC members. So the majority of the commissioners submitted names specific to justice item, but that did not stop several other commissioners who wanted to submit names, and no restriction was placed on any commissioner to submit multiple names.
Right.
Okay, so let's move to the.
Just to clarify, I'm so sorry, Commissioner Slonim, if I could just say one more thing. So I also, just moving forward, when we're submitting names for subcommittees, I think that if we could be specific in who we're trying to submit the subcommittees for, because I can't imagine asking someone and saying, hey, would you like to serve on a subcommittee of the Patient Protection Commission? People would be like, I don't know, right? So I think that if we could be very clear on how we provide that too. Sorry.
So that's fine. I think we need to move on. We are going to accomplish something today.
One more point I'd like to make. I think that there's two issues here that are relevant. One, the wording from the email is actually not specific to the Millbank. Also, please provide names of any persons you would like for this commission to consider as a member on any of the subcommittees and or the stakeholder advisory committee under agenda item 5. And when the list was provided by subcommittee, they were deemed committees. They were put into a generic list, not into the subcommittees as had been recommended.
So I think, Tony, to
correct,
close
it's for the entire agenda item.
If I may close the subject, because I think we're losing some precious time. So Tony, to your point, whatever was transmitted, all those names can be considered for what committee it is as we move forward. So the names have been submitted, whether for this Millbank or for other committees. That discussion still got to come. And those names could still be considered for the other subcommittees that may have expressed an interest to the commissioner. So for today's discussion, so we can at least accomplish something, we are trying to focus on those people who may have, want to serve on this once we decide how many, and then consider the names through the commissioners, at least for this. And then the others, or the other subcommittees that can still continue, and the names that you have submitted are still there. And if people have more new names that can be submitted before the next meeting, they can be included in the list moving forward in the next meeting ahead of the agenda deadline. So we can still add to that down the road. So if we can move forward on the Millbank discussion, let's go to the next commissioner, please.
Okay, and just to let you know that we have Commissioner Babette Bond joined us.
Okay, so who's the next in line to?
The next one would be Commissioner Mason Van Houweling.
Okay.
No other comments, Chair Khan. Pretty much agree with everything that's been said. I just don't want to get us too, I know we want to be very inclusive. We do need additional help, and we do need to find experts in this particular subject that we're talking about, Millbank, but also the other subcommittees. But I agree with Commissioner Flood, is much like it took us a while to get to know each other and get our footing and get momentum, these subcommittees will go through the same process. And I just don't want us to have too much scope creep and it slows us down. I agree with Dr. Barron's earlier comment. It'd be great to have a commissioner champion that can relay the intent and spirit of the conversations, but supportive of the conversation. But ultimately, Commissioner Flood's point of let's get this done and get it moving. So thank you.
Thank you. Next commissioner.
Commissioner Teresa Bohannon.
I just want to ask a point of clarity in where this advisory board fits in between our work on this project and then also where the executive team is going to, because there's still another body that would have a role. So I think just understanding and making it very clear to whoever the body is of this advisory board so that everybody kind of knows their role and their position and their responsibility. Because it sounds to me from what I'm hearing is that this larger body will kind of be sort of a place to collect a lot of information and opinions that would roll up to us, and then that we would potentially roll our recommendations up to the executive team. So I just want to get a little clarity on that.
Sure, I appreciate that. And Chair Khan, if you may, I can answer that question.
Yes, please.
Sure. Thank you, Commissioner Bohannon. I believe what you're referring to is the Nevada executive team that I have established internally to kind of help with the program's work within the state. And so the Nevada executive team is a team that I put together internally that helps me brief the state and brief the governor's office and get guidance and feedback from them. But that is an internal team that I get advice from and that helps guide me. I have been designated by our governor as the state official to lead this program within the state, but I am someone who likes to have assistance and would like to have full participation with other state agencies and other head of agencies and other members of the governor's cabinet. So that is just an executive team that I put together internally to help me lead this program's work. The advisory subcommittee is an advisory group that will help you. The purpose for that is to help guide your recommendations. So it's two separate groups. I believe that, does that answer your question, Commissioner Bohannon?
To a degree, I still am unclear of who is the ultimate person making, or not person, who's the ultimate body that's going to be making the decisions. Like at the end of the day, all these different people are coming together. It sounds to me like the executive team maybe doesn't have as a significant role. And we have a larger role in the decision-making process. It doesn't really matter. I just am curious how that's going to.
So if I, go ahead,
okay.
go ahead.
No, I can answer that. I mean,
I guess my only concern is with all these different people is there's going to be a lot of cooks in the kitchen. And when it comes to healthcare and healthcare costs, there's a lot of divergence in terms of opinions. And so I'm just thinking of how is this going to be a very deliberative body that's collaborative and we're moving in the right direction.
So ultimately, and thank you for your question, the commission is by and large an advisory commission. It's put together as a recognized public body to provide recommendations. This commission does not have the authority to mandate or to do anything that the state doesn't have any power to mandate anything within the state. So the only role essentially is the build of consensus and a set of recommendations to present to our governor. And so outlined, and even in his letter to this commission, he's asking for this commission to provide recommendations. And so ultimately, this body will be providing recommendations, and the governor will also seek recommendations from either the Nevada executive team. Oftentimes he'll ask for my view, and I will meet with the governor's office on various issues. And so it's a combination of recommendations, but ultimately it will be our governor's decision on whether or not to follow a set of recommendations. And to that extent, also, if this body should make recommendations to another body like the legislature or local jurisdiction, you would just be presenting recommendations to that body and they would make the decision. They have the authority to either agree or disagree.
I think we need to move on because we need to complete everybody's input and see if we can have time still to deliberate final component, at least this subcommittee.
Okay. I just want to make sure, Commissioner Bohannon, does that answer your question? Okay, then maybe we will follow up afterwards and I can send you our statute so you can see what our jurisdiction is and what our scope is as defined in law.
So Sarah, I just wanted to clarify really quick. Because I was talking to Mr. Bailey about this, that other states, so how this actually becomes in law is two different ways, generally. The governor can choose to have an executive order. So he could take our recommendations and make it an executive order and create whatever. Or potentially someone else could take legislation, or the Patient Protection Commission could decide to take their legislation in 2 years and do
Correct,
something.
but it's all recommendations is the point that I'm making. There's no authority given to this body to do anything that this commission puts forward, whether it's legislative, executive, local. It is a set of recommendations given to the body that would ultimately be making the decision, whether it's the executive branch through executive order, whether it's the legislature through proposed legislation. I just wanted to make sure that this commission is not a body that makes decisions. It makes recommendations.
Sarah,
Use our BDR, no?
Yeah.
I'm just trying to understand. Like, couldn't we use our BDR for something like this?
Yes, but the BDR is exactly that. It's a bill draft request. And then the ultimate decision would be at the legislature and we cannot compel the legislature to do anything. We can only make a request.
Got it. Okay.
Okay, so could we please move on with every commissioner so that we come to some final decision making? Who's the next in line?
The next would be Commissioner Yerleni Roa-Dugan.
Hi, okay. So my recommendations would be to, like Michael Bailey said, have members outside the commission that have expertise in things that we are not representing, or maybe find more representation of the members that we already have in the PPC, like consumer voices. I would recommend that we have the subcommittee to be between 10 to 20 members total, which would mean each commissioner would be able to volunteer or appoint, I don't know what the word is, 1 or 2 names each. So everybody gets an opportunity, a fair opportunity to have representation in the subcommittee. And in terms of the scope, to follow the scope that was done by the other states. I don't think that Michael actually read what the scope was, just kind of summarized, but it sounds like it's just an advisory committee and they don't make any decisions. So that's it for my recommendations.
Thank you. Next commissioner in line.
Okay, it looks like we have Commissioner Babette Bond.
Oh, good. I'm sorry to have missed stuff up to here. I'll try not to be repetitive. Thank you for dealing with.
Sorry, Commissioner Bond, just so that you know, your letter has already been read into the record. Earlier it was completely read and it's part of the public record now.
I really appreciate that. Thank you. I didn't think I'd get here at all. And I've missed some of what Mr. Bailey said, but what I think my key issues are, I think that the commission members should have equal representation. So we should make sure that the whatever becomes the advisory committee, every member of the commission has the same amount of membership that they recommended for that. I think that when I saw the list, there's a lot of things that Mr. Bailey talked about that we don't have representation on in terms of expertise that we need. So whatever we do today, we need to leave room for the rest. And then thirdly, I think that my big concern is I actually submitted a name that didn't make it to the list, so they can't even be considered today. And so I think that what needs to happen, what I would recommend, is if we're going to go around and everybody gets to choose one commissioner choice today, then go back to Mr. Bailey and see who's missing. And then our next meeting, fill in the gaps and provide names if we didn't get the opportunity yet, or if there's areas that are missing, because I think there are. We don't have any employer representatives on this advisory committee. We don't have, there's a bunch of payers that are not on this advisory committee. Some of the things that I've heard you talk about, we don't have a health economist. They're not in these names. So I feel like, can we get our first vote today, but then have some outside expertise help us with filling out the rest in the future meeting?
Just so that you know, Commissioner Bond, the other items that were suggested from Mr. Bailey and some of the commissioners was consideration of IPA representation, Medicaid managed care, possible consideration, employer purchases, a possible consideration, consumer voice is a possible consideration. And maybe an economist was alluded to, at least by Mr. Baylor. So these were some of the other thoughts that have already been talked about between the consumer and the payer and all those stuff. So they have already been talked about.
So is it appropriate to choose one of the people on the names this today and then go back, because most of the people on the names are not these people, and the list is very heavily represented by names submitted by
right. So the idea is by 12 o'clock, if we can, there were a few things in my opening remarks I had indicated that we need to develop first to deliberate on the scope, which we have to define, which we haven't done yet. We are relying on Mr. Baylor to give us the scope from other states for these committees as a starting point. And the purpose of this, which he will tell us what purposes have been defined in other states for this advisory committee, what purpose it's going to serve. And then it's a membership part. So these three things we have to deliberate on as we move forward. So we're taking every commissioner's input, and then we can, at the end of this input, and decide how each item, how do we proceed, and hopefully come to some consensus or by vote.
Okay, so I'm all ears. My understanding is we're going to wait now for Mr. Baylett to present to us what we need, and I thought that already happened, so forgive me.
No,
that would be great.
Not yet. That was recommended by several commissioners earlier on, and so he's agreeable to do that. All right, next commissioner, please. We're missing some commissioners' input, I think, still.
I don't think that, I don't think we are. I think if I've missed anybody, I apologize, but I think I'm at the end of my list. And if you'd like, we can go back to Mr. Baylett just to kind of wrap up and give us a direction on the next steps if you are not prepared to move forward today. So we can just have clarity on the process for the next meeting, if that's agreeable.
So, Ms. Baylor, you heard everybody's opinion. If I may summarize what the commission is expecting from you, ASAP, a draft of what potentially is working in other states in terms of scope, purpose, membership. You have alluded to some of those things earlier on. You alluded to some of the other areas that were missing, and then some of our commissioners added some like IPA, etc. You mentioned. There's a couple of our commissioners had some other thoughts, which are in my notes at least. So if you could summarize scope, purpose, etc., at least verbally, and then maybe give it to us in writing, my thought would be then everybody should have an opportunity to look at that before our next meeting, so that everybody knows what you're suggesting as a draft, and we can vote on that draft to agree with that or have our own additions or subtractions from it for Nevada. And then the membership list is the second point we need to decide, other than what you have based on what was talked about today, but other areas need representation. That's number two. And then the third thing the commission needs to decide is how many members we would want to have total on this. You mentioned that other places are from 15 to 20. So the commission needs to decide how many members. And then depending on the numbers we decide, then for fairness to every commissioner, if we decide for 20, everybody can give 2 names. If we decide for 15, since we are 10 members, I think we have to be even so that everybody gets even opportunity to submit names. So that's my summary. So could you please proceed with your perspective?
So I will be happy to put in writing the suggestions that I made at the outset of your conversation, that you convene a subcommittee for a time-limited purpose for the express intent of informing your deliberations on the benchmark methodology and perhaps on some associated activities, that the body be broadly represented to bring to voice some perspectives not here and to amplify others where there's limited representation. That would include different types of provider organizations that would be likely subject to measurement against the benchmark. It would be in consumer voices, employer voices, and some additional insurer voices. In addition, there might be the opportunity to bring in a technical expert or two with an understanding of health economics or health policy. All of these are general suggestions. There's not a formula for this. I do encourage that you make a decision at your next meeting, because timeliness does matter here, because you're already making draft recommendations. And if this group's convened too late, you will already have discussed everything by the time we convene them. So I do think that there's value in you making a decision. This is not a decision that's going to resolve world peace. So I don't think you should perseverate over it too much. Just find a representative group of people. That the people who are not placed on this body will still have other opportunities to provide input, both through the public input process. And I know that Sarah is planning on doing some stakeholder outreach to augment this body as well.
Okay, so thank you. Based on what we just heard, anybody has any additional comment?
I do.
So then I can summarize it. Is it Commissioner Bond? I saw your hand up.
Yeah, thanks. Sorry, I want to just retract what I said about we should all vote on one person today. I think we just have the wrong list for what he just described. And if we are only going to have 20 people, some of that has to be reserved for the people that the state needs there to make sure the work can even get done, right? We have several recommendations on that list from the state or from state-related bodies, which would reduce the slots available for the positions that we otherwise need. So I think we should start over.
Okay, so anyway, basically we haven't made any decisions yet, so that you know. We're still deliberating on what should be like, what should be the structure. And Mr. Bailey has been assigned that task to get back to us on other places in the draft form in writing to be shared with every commissioner, so that one can look at that and agree, as I said earlier, or change, add, or subtract to that format. Number one. Number two, we haven't decided on the number of people that should be on this committee. He had mentioned that in some of the other places there are about 20 people. We have to now deliberate whether we want 20, 10, 30, 100, whatever it is. That's number two item to deliberate. And then depending on the number we decide upon, how do we evenly distribute that for each commissioner to recommend to make sure that we included the IPA, Medicaid, managed care, consumer voices, et cetera, So there were 5 or 6 items that were not included previously, but based on a discussion with the commissioners today may have to be added. So we'll need additional names anyway from commissioners to cover those areas also, and then pick so that all areas are covered and represented. And we may have to add, as mentioned earlier, perhaps an economist, et cetera, that Mr. Bailey has been alluding to. So I think going forward now, the number 2 item that I would like to narrow down now is, once we receive the draft, how many people we in Nevada would we want to be on this committee? That's what we have to decide. 20 was, he mentioned 1, but it's our decision whether we want 20 or 15 or 100. So
could I make a suggestion to facilitate your process? So my suggestion is that the members have the opportunity to resubmit names based on what I've shared and what I will write up. And that they go to Sarah, and that Sarah proposes a slate for all of you based on all of your names. If there are any holes that she sees, that she have the flexibility to add a couple of names to fill the holes, and that she presents to you in advance of the next meeting for a vote at the next meeting, a slate that would represent all of your input, so that you can take action at the next meeting and not have to negotiate every individual name.
Okay, does that make sense to everybody on the commission? Anybody objects to that, please raise your hand, or has other thoughts?
Commissioner Bond?
I don't object. I think that's a great idea, but I do think we shouldn't be, I think we should have some guardrails around how many names we give Sarah. I don't think she should have to dig through, 18 names from one person and 1 name from others. I think we should have a cap. We should give her, 3 names.
So as we discussed, we still haven't decided, do we want 20 members? Then we can decide 2 from each representative for this committee. And one has to make sure there's no duplication of the organization or entity that these people may represent. For example, we don't want 3 people recommended by 2 different commissioners from the same background, perhaps, for diversity. In other words, from patient advocate, we don't want 2 commissioners submitting 2 names. That makes it 4 patient advocates, and maybe takes away from some of the other organizations that need to be represented if we cap at 20. So we may want to first decide the number, and then we can go to how many each person can recommend specifically for this committee. There are other committees, and names will already have a long list, and some of those may fit into some of the other committees, or the commissioners may be thinking about some other committees also, and that's why I gave extra names, thinking that there will be a whole lot of other committees to discuss. So does that make sense? And so can we vote or decide about the numbers of people we want, and then we can decide how many from each background we would prefer to have. And so the commissioners can narrow down their recommendations to fit into some of those areas. Is everybody in agreement to at least decide now how many people for 20 members? Could you kindly raise your hands, those who think 20 is a reasonable number? Sarah, can you see all the hands? I cannot.
I think.
I have a question.
Okay, hold on. There's a couple of hands raised, so I'm a little bit confused as to. I know everybody's raising their hands, but you've got Commissioner. Are we raising your hands to your question, or it's not clear to me if they're raising their hands for a question or to answer your request, Chair? I'm sorry.
If anybody has a question, they go first then.
Okay, can we just to make it clear to me, everybody who has their hand raised now, please keep it raised if you have a question. Otherwise, can you remove your hand and then we'll go back to Chair Khan's request. Okay, so looks like I've got Commissioner Bohannon and Commissioner Flo Khan who have questions, correct? Okay, great. Commissioner Bohannon?
Are people, because there was a little bit of a discussion of people who might be interested in serving on this subcommittee or advisory board. So are we, if we're limiting it, are we then limiting people who might have an interest and whose voice we might want and we may miss? So, you know, I'm just kind of throwing out the idea of maybe having up to 25 members, having language of up to, not necessarily having a hard, fast number. And then that way we can each submit 2 to 3, and we decide on 20 people, but we maybe leave 5 slots sort of open for people who do have an interest or flexibility, because I imagine there might be some ebbs and flows in these subcommittees. People may come and go, it's volunteer. So I just kind of think we might want to be very flexible. So I'm just questioning if we're opening it up.
If I may, perhaps one way, if everybody else is agreeable, one could say no more than X number of people. For example, no more than, it has to be an even number so everybody has an opportunity to represent appropriately. So should we say no more than 20 or no more than more? So that's, we can solicit that from other people when we take a vote on the 20 number, and whether they want to go along with your thought also. There was one more commissioner who had a question.
Commissioner Khan?
Yes, thank you. I was kind of along the same lines as Commissioner Bohannon in that I think as commissioners, we should be limited to 2 each, maximum 3. I would say 2 each, that's 20, but leave slots available for state department participation, because I think that's important and we need to make sure we've adequately been represented at the various state departments that are going to need to have a say in this. And then I would also suggest that we leave a couple slots open for the public who, you know, we want to make sure that their voice is heard and they may not have had an avenue into this. And I don't think you put a lot open-ended, but I do think you could say maybe two public slots or 3 public slots, whatever we agree upon. So I would actually suggest that from a commission standpoint, we limit it and say 20, and then we allow ourselves maybe 10 additional slots for a couple for the public and then the appropriate state departments to be represented. That would be my thought.
So I think the public part is already part of the list that we have talked about. which was added on, or at least recommended today, besides the IPA and Medicaid, managed care, et cetera, et cetera. So,
Chair Khan, if I may, just just insert one other thought, and I really appreciate the dialogue and the comment about including some public members, and I do think that there are a lot of state representatives who would like to participate to help facilitate your discussions. But when we start getting into the 30 range, even the 20 range, I am very concerned about the manageability of that, particularly with the uncertainty around our open meeting law requirements. We are now shifting to having the state open up as soon as June 1. What is unclear to me is whether or not we will have the flexibility as a public body to continue to meet virtually. So this is something that is okay and not really concerning resource-wise if we have the flexibility to meet virtually and those choose to. But if there are restrictions placed in which we need to have a in-person meeting, getting a facility that has 30 people at the table is going to provide some obstacles for us. So just
I think if I may back, we started with a number of 20. At least we have already talked about the various organizations and entities that people may want to represent. And I'm sure there are not more than 10 organizations that we have talked about, including patient advocacy groups, which is public, basically. So if it is okay with the commissioners, we really want hands raised if everybody is in. Is 20 manageable, Sarah, from technical administrative point of view?
Yes, I think 20 is more manageable than 30.
Okay, so let's take a vote of commissioners. Please raise your hands, those who want it to be 20 members on this advisory committee for Millbank. Do you see your hands up, Sarah?
Sean's hands up, but he's not using his hand thing.
Okay, got it. I think, yes, we have more than the majority of the hands raised. So I think it would be better as if somebody's in disagreement to raise their hand. But I think you've established the majority
Okay.
of all of the.
So that's number one question we have established. Two questions actually: the draft from Millbank and this total number. The third one is, if it is going to be 20. It's obvious to me, at least, if somebody disagrees with my math, 10 commissioners over here. So each one, in fairness to everybody, has the opportunity to recommend 2 names to this body. So that'll make it 20. The only question I have is or concern, and Mike, you may want to help us out. We don't want, for example, unbeknown to them, 2 commissioners recommending Representative IPA, for example, and I'm recommending 2 people from IPA or another commissioner. Now you have 4 people from IPA. So we'll have to narrow that down at the next meeting. There are already 4 names. Which ones, I mean, hypothetically, how do we make it only 2 from IPA or whatever we decide as the numbers? Mike?
Yeah, I would empower Sarah to sort that out.
Okay.
You all submit the names and let her figure it out. And if we get too many IPAs and we get no consumers, then Sarah will sort out who are going to be the IPAs and she'll identify consumers. I think that's the fastest way to get this done.
Okay, so is everybody in agreement, 2 per commissioner for this advisory body? Let's do it. Anybody opposed to that? Raise your hand.
Commissioner Bond, and then we're going to go to Yarleni Roa Dugan too.
Okay. I think Dr. Khan 20 is great, but I think that if we're all submitting 2 names, then that gives no room for the people that we need to backfill that aren't covered, and it gives no room for at least the 5. I think there's at least 5 state agencies that need representation on the committee. So I think that if we're going to do 20, that's great, but then we all submit our top name, and then Sarah has to figure out what we don't have.
And I think you're right. My thought obviously is if we submit 20 names, then they're there. Now, if we require some help from the state, et cetera, whether it's Whitley or whoever else from HHS,
Not
I don't
Whitley.
know. No, I'm just saying.
He doesn't want that job, I bet.
Whoever,
Oh, it's
whoever,
not just-
whoever the state wants to be represented on this, I don't think too many people would be wanting to that. They're technically not appointed by the commission, but based on our function under the executive branch, if the executive branch wants to send 1 or 2 people or just to be observers, they can do that. But I don't know how we can restrict to 5 executive people or 2 executive people. I leave it to the executive branch to decide who they may want to just sit into these meetings for any technical questions. How do the other commissioners feel about it? Anybody opposed to that? Leave it open. Whoever the executive branch says they want somebody to sit in from the executive branch.
You mean in addition to the 20?
Right.
Yeah, I'm okay with that.
Yeah.
You want
Anybody?
both? You want hands?
Yeah. We want hands.
So just for clarity, so it would be in addition to 20 to sit in, but they would not be formally placed on this advisory committee?
Yeah, they will be there to sit in for answering of technical questions. If they're proposing something to us, they may want some clarity from the state agency. So they are right there to answer it.
No,
so
then
Greg,
Dr. Khan, I do have a problem because I think the people that know the information should be voting members. I thought you were saying the executive branch, like the governor's office could send somebody to observe, not the state agencies that have the expertise. I think they need to be able.
Well, technically, they're all under the executive branch, the governor. So whoever decides, somebody has to decide who they want to send in for observation or given technical input. Maybe HHS has to decide whom they want to send in for observation. And really, it's just for observation. The 20 people will make the recommendations. These people will give any technical advice that they may want.
Okay, so I just oppose that because I think they're the ones that should be to decide what we can do.
That should be used. Sorry, I didn't get the last part.
I'm sorry, I'm speaking out of turn too. I'm not being very meeting appropriate here. Just blame it on the Novocaine today. I would say that I think that some of the people that we need information from would be on the committee. I think that we get in trouble when their voices are heard, but we don't really include them because they're there to observe but not participate. So I'm concerned that we'll have 20 people that we appointed and then some expertise that Sarah has to figure out how to backfill that we didn't get on our list. And then we'll have the state agencies. That's still going to be 35 people. I think what we should just all give one name to make up for all the other things we need.
So the only other option to narrow down our discussion is limit the number of technical people that could pay, say, for example, no more than 5 or something to that effect, so that it's not an overwhelming thing, or no more than 2 or whatever it is, other than the 20 people. Let me hear from the other commissioners also, please.
Okay.
Well, I've got a question. So our state...
If we can, Yarleni has been waiting. I'd like to go to Yarleni, then to Commissioner Flocon, and then Commissioner Flood, if you don't mind, go to you unless you have, okay, good. Just want to be fair.
Thank you so much, Sarah. Okay, so yes, I've been waiting patiently because what I want to say is it's actually what we're talking about. So my recommendation is that we all give our 2 names for the subcommittee. And how about we decide now as a commission how many people we want from each group to be represented. So Michael talked about large medical groups, insurers, Medicaid managed care, consumer voices, employer purchasers, and maybe somebody with, what did he say, an economist. So that would be 6 groups. I don't know if we have more names that should be, more groups that should be in the committee. And let's decide, okay, we only want 4 consumer voices out of those 20. Only 2 large medical groups to be represented, and 2 insurers, and 2 Medicaid managed care. Can we decide on those numbers now? That would facilitate Sarah's job too in choosing, because that way she doesn't have to decide by herself. how many consumer voices she's gonna have. We give our two opinions, and then she already knows, okay, she needs to choose 4 consumer voices based on what we decide today. That's my suggestion.
Okay, who's the other one online?
Commissioner Flo Khan, and then we'll go to Commissioner Flood.
Sarah, my issue is that we all want to have a representative on this advisory committee. And with all due respect, if Sarah's getting bombarded by different groups, and then she gets to, and we only get one, and she has to pick and balance, then one of us or one of our, as commissioners, may not have a voice in this advisory committee. And so I really worry, like, we all know what's needed on this. Put forward your best name. And I guess if that name isn't selected because we have too many of one thing, then I think Sarah should come back to that commissioner and we have an ability to put in a different name. Otherwise, some of our voices as commissioners may not be heard on this advisory committee. And I think that's problematic. So I think we have to be, there has to be some allowances there to make sure that we each have someone on this advisory committee.
Okay, any other commissioner for any opinion?
Just really quick for a point of clarification to Commissioner Flo Khan's point is you're absolutely right that there's no restriction placed on adding in additional names at another meeting. You all have the flexibility to manage these subcommittees, any subcommittee that you create as you are meeting. And so there isn't a restriction and no way to kind of pull back. If you start at even a small amount, you can always make an addition or make a case for it later. That is always an option to you.
So I totally agree with Commissioner Khan, but I think also Sarah's so good at coordinating behind the scenes with like the meetings that if you could just give us the feedback when we submit a name, like, oh, it's already been submitted, or we have a heavy amount of that, and try to give us a chance to pivot. Because it would be nice to just have a nice cohesive list at the next meeting and not have to kind of go through this of actually your name isn't going to be selected. The other thing I'm hoping to advocate for is so for me, the rural voice here, I think, is I might have some non-traditional participation, right? Such as, you know, I talked to Mr. Baylett, and the rural hospitals are largely not going to be affected by the benchmark. However, rural healthcare, it's good to have that perspective or voice at the table still. So I'm just hoping that we don't have to be so inflexible that it's only these people, that we can allow for others just to be able to fill those perspectives that we need. And then finally, I was thinking about this state thing, and it's interesting because my experience of state officials, I agree 100%, Commissioner Bond, that we need their expertise and, you know, input. But they don't really give much voice in voting meetings or stuff like that, because they're really just like kind of staff of the governor or whatnot, right? They kind of have to follow that lead. So, I mean, do they vote in other situations? Or, you know, I mean, I know they're there to provide technical assistance, but I just want to clarify their role. So those are my comments.
Okay.
So if you remember, Mike, correct me if I'm wrong, you had earlier mentioned this is not a group that votes on consensus to make their recommendations. It's just that there are various voices and you bring their voices to us rather than they are quote unquote voting members, and then they have to take a vote of everybody on every item or subject that they are going to recommend to the commission. Mike, is that correct?
That is correct.
Great.
Right. So since we don't have a vote anyway, so the bottom line is I still believe whoever wants to come for technical assistance, they can come and sit. I can guarantee you no more than 1 or 2 people will show up to begin with. They're so busy to begin with. So that's my personal view. Who else is in line?
And Chair Khan, if I can, that I might help make this a little bit more efficient, just kind of recapping the comments that I've heard, and also to Mr. Baylett's point that what I could propose to do for this commission, I am a little bit concerned about having dialogue in between meetings that reflect me sharing information from other commissioners. I usually refrain from doing that, Commissioner Flood, but I think to Michael Baylett's point, what I would be more than happy and willing to do is if you set a cap at no more than 20, soliciting everybody's name. There's no restriction on what number names that you solicit, but let me formulate that list based on your recommendations, capping it at 20. And then when you go into your next meeting and make your recommendations, you could still decide, oh, no, that's not the person I wanted somebody else. And then you still have a limitation of only one person per commissioner or two, however you decide it. But at least when it comes to creating the list of 20, I would solicit your names and I would put the list of 20 together. Is that how you were describing it, Michael? Is that what they did in other states?
Yeah, so in Washington, they did this recently, and they had the members of, it's a board in Washington, they submitted names, and the state put together a slate. They talked about it at one meeting. People gave feedback that they thought there were a few perspectives that were missing. State went back and added 3 people, and that was it.
Okay.
Okay. So any other commissioner that has not spoken on this, so we can wrap this up in a timely manner? We have a couple of additional agenda items still.
Is that all? I don't think anybody has any questions. Commissioner Bond, did you?
Well, I'm trying to honor Dr. Khan saying, you know, if you haven't already spoken yet, and I have, but I do think that if they're asked to give technical assistance, they do give technical assistance to state agencies. But if they're not asked, they don't. And if they don't have a way to engage with us because we didn't ask, I just don't want to be in that situation. So I'm glad that we're clarifying who gets to vote. I think that's really helpful. But I do think it's upon us to make sure we get as much input as we can from whoever participates. And I'm sure the commission will direct the committee to do that. So I just want to make that on the record.
All right. Any other commissioner who has not spoken or has thoughts? So if I may summarize from some of the notes, there is a consensus for 20 people. You can give 40 names amongst yourselves, but they will be narrowed down to 20, 2 from each commissioner in the final analysis. Sarah will try to decipher those names and put them together. And we come back at the next meeting, we still have the right to agree with her or modify those names or change those names to still keep it to 20. So it doesn't restrict you to put in only 2 names, and then the commission decides, oh, this one name of yours is no good. And then we are going back again, trying to, as a commissioner, to find another name. So you can put in 3 names or whatever it is for this committee. And then Sarah, as Mike has suggested, can narrow it down to the 20, make sure that most of the areas, advocacy group, this, that, and the other, or patients are included in it. And then we can deliberate and say if these 20 are acceptable from each commissioner too, or we need this one representation, perhaps it's a duplication or whatever. So perhaps adjust that. So we can still deliberate on the final list at the next meeting after everybody is given their names. Yes, Babette.
I'm sorry, but we're still going to end up with 30 names because we're still going to have a bunch of slots. If we all get to appoint our 2 people, we're still going to have a bunch of slots that didn't get filled by the expertise that Dr. Bailitt talked about. So I don't see how we fill those slots in the way you're explaining it.
Right. So the slots of expertise, we have talked about several already.
Yes.
And if
but those aren't the names we're providing. We're providing who
I
we
know.
want to
So now,
right?
see, this was not defined before when the names were solicited. Now it's defined. So
Okay.
hopefully we'll all focus on some of these areas that we have defined or at least talked about at length earlier, so that they try to make sure that some of these areas are represented in their names. And if there are 3 or 4 names from the same organization or background, then the commission can say, no, or Sarah will decipher it. There were too many people from this organization recommended by 2 different commissions or 3. So then we narrow down to 2 of them best suited for that. So we can still deliberate. So it's not final until we deliberate. It'll still be 20 and it'll be still 2 people from each commissioner. There will, I can guarantee you there'll be no open slots. One way or the other, if everybody is focusing on these background people, whether it's IPA or consumer, and they're all trying to focus on that.
And Chair Khan, if I get the direction from this group that it's no more than 20, I will take the feedback from Mr. Bailitt on what the advisory committee should look like. I will take all of your names into consideration, and I will make sure that out of that collection of names that I put forth, a list that reflects not only your recommendations, but what Mr. Baylett suggests is the makeup. And that list will then be generated by me for your consideration at your next meeting.
Okay, so if there is no other subject, so I've tried to summarize things, so we'll get a draft, will be circulated to the commissioners from Mike on the scope, etc. We have agreed on 20 people. Each one will have 2, and Sarah, what you just mentioned, she can look at that and discuss with Mike and move forward on that. We'll make sure the organizations that were mentioned earlier that were not originally considered in Mike's first thing, but he added some and we added some. All those areas are covered as best as possible. So we can wrap up on this is an agenda item to be continued at our next meeting for final action on this one. Correct, Sarah and Greg?
Yes.
Okay.
And then just for clarity, to make sure that in case that there is a slot that isn't filled based on the recommendations, my direction is so that when I put this list together, if there is any hold or gaps, that I will, try to fill those slots accordingly for your consideration. So there could be a scenario in which I go outside of your recommendations, but again, that's not definitive. It would just be to put it on for your consideration at the meeting.
Okay. Good enough. So I think we'll move on to the next agenda item. The action on this is deferred till our next meeting when we have all the information. So now we have 2 items A and B on existing subcommittees. They're not there yet, but we have talked about them as I mentioned in the original remarks. The Healthcare Cost Subcommittee, Medicaid Subcommittee, Network Advocacy Subcommittee. These were talked about before. And then the potential new subcommittees that have been talked about is Workforce Quality and Advocacy and Stakeholder Advisory Committee to the PPC for pieces. And that's the one we've already done. So, or we're in the process of finishing it next week. So my thought on all these is the same thought process should prevail for these committees. We have to define the purpose, et cetera, like we talked about for Milbank Advisory Committee. First, the scope, et cetera, and then use the names or some of the names that have already submitted, decide the number of people we want on that subcommittee, et cetera, the background of those people. We'll have to go through the same process for some of these subcommittees that we are going through for this one. How many members who, if 10 people want to submit one, then they submit one name each for that subcommittee. So my question to you, Sarah, is there are 5 subcommittees talked about by commissioners, 3 previously and 2 new ones. So we need to decide today. We cannot go every committee at the same time. It's a lot of headache for Sarah to keep track of all that. So we need to decide which next subcommittee we want to tackle with the definition of scope, process, et cetera, and who will provide us that. Here we had Mike to provide us the draft of scope, process, et cetera. Who will do that for us, Sarah? And then which committee?
So before we go forward with all these subcommittees, I feel like some are kind of duplicative, and I don't think we've even reached consensus on the topics. And I've heard feedback from commissioners, I don't know where, that maybe we should only have 3 subcommittees, this whole 5 or 6. So I don't know if we've come to ground.
You're right. I was about to say that. We have to, we are about to, that's what I meant. We have got 5 subcommittees. We haven't concluded as a priority which one, or whether we even need these 5, or we can, blend into 2 and cover the subject. So that's a challenge we have, and we need to decide at least before 12 noon today about what do we want to do with this. So the question, the way I would like to frame it is, which committee the commissioners think we should consider first, or combine which one if we have those thoughts. I think if we can start with which subcommittee majority feel should be our next priority, or which subject rather should be, whether the subject we want to healthcare cost which blends in with Medicaid subcommittee or not. Network adequacy is a totally different thing, and there's workforce development, a lot of interest in that, and then quality and advisory. So which ones do we want to handle next, and whether we want to combine any? So I would like
It seems that like workforce is completely separate and quality is kind of completely separate, where some of those others kind of are going to fall into the other advisory group that we had a long discussion about. So I would propose to narrow down to those two.
So are you suggesting the healthcare cost, Medicaid, and network adequacy be combined into one and leave the workforce development and quality and advocacy separate?
Network adequacy and quality might kind of blend together a little bit. So those could maybe be combined into one. And then I think workforce development, it seems that there's general consensus, and that's definitely something that would be separate, that I feel, then the other three can fall into the other work that we're doing.
So Sarah, could you go in order to make sure we come?
Yeah, so Chair Khan, it's definitely your discretion on how you want to recommend what structure this PPC considers and what's most appropriate. For capacity discussions and resources, for me, it would be very helpful if you could start your conversation on the scope, maybe instead of it by topic, to really understand what the purpose of each subcommittee is, so that way I can adequately opine on resource and staffing, and so I have a deeper understanding of what the expectation of each of the other subcommittees are. So if you could just frame the discussion, it would be more helpful for me. It's just an ask. You could continue your discussion on topic only. It's just more helpful if I have clarity on what the purpose of your subcommittees are first.
So because each subcommittee may have a different purpose. That's our challenge. So each committee's purpose and scope will have to be defined because it may be different from the other.
Yes, I'm just saying from my perspective, it looks like there is a desire to find a solution without defining a problem first. And so it's just confusing for me, but I could be, you know, a black sheep off to the side. I'm just saying it's harder for me to follow, and I just want to make sure that I can be as helpful as I can to this commission. So that's just my thought.
So let me take every commissioner's opinion, so then we can narrow things down a little bit more so that everybody has their opinion. So let's start in order, Sarah, so that, because I said I have a hard stop at 12, so we need to conclude it at 12.
Yes, and we do need to have, by open meeting law, time for public comment. So we need to conclude, I think, within 10 minutes to allow time for public comment. Is that adequate time, Greg? Okay. So I have three commissioners whose hands is raised. Should we start with them first?
Yep.
Okay. It looks like, I think, Bobette Bond, are you first?
I can be first.
Sure.
Can you hear me? So I guess my input would be, I don't think we should start a committee until we get this Millbank advisory committee structured. I don't think that we have the time or the resources to do it. I would defer to others who think can identify how we would do more than one. But if we're going to do one, I would like it to be the cost committee, but I would not like it to include Medicaid, because Medicaid will swamp anything else going on in the cost committee. Medicaid has a complete empire that we have to work on, and it deserves, you know, it deserves a lot. So I don't know how to put those in the same committee. Second, I would not like us to add any more committees than the three we've already approved, because I do think network adequacy has a whole committee in the state already. I don't think that we're going to start over on network adequacy in this commission. I think it belongs where it is with DOI. So that is my input. If we get, I would like 0 until Millbank's done, or I would like 1, and then that would be cost. And then I would like a conversation about how we do Medicaid in that. Because I think
if I could request the other commissioners, those who haven't spoken, please, we have 10 minutes. It looks like I may have to defer the whole thing for the next meeting, but at least we'll have some input today. So let's hear from commissioners we have not heard from.
Okay, just so everybody knows, I'm going to start with Commissioner Tony Slonim, and then I'll go to Commissioner Flo Khan.
Thank you, Sarah. Tony here for the record. A couple, 2 points. One, We are called the Patient Protection Commission, not the Cost Commission. So I believe that there's a great umbrella of work going on that has to go on with the Millbank program. I think it's evidence-based. I think it's cutting edge. I think we should all be behind it and make sure we do what it needs to succeed. And I think that there's probably a couple of other places where we will better clarify the needs for the pre-existing subcommittees, the healthcare costs, Medicaid, et cetera. I'd like to spend some time, energy on the Patient Protection Commission, dealing with quality and the people who serve the needs of those patients, because I don't think we're doing an ample job in this state. We're tackling costs on one side. I think we need to pay attention to some quality and the way care is being provided. We're underrepresented in doctors, nurses, pharmacists, therapists, every other darn thing in the state, and significantly, and it's contributing to adverse quality outcomes. I think I'd propose that we, if we were going to do one thing, I appreciate Commissioner Bond's point, don't take on too much. Maybe there's, put all our energy into Millbank and add one, and if we were to add one, I'd say I advocate for quality or workforce.
So let's continue to narrow this down, and please be respectful of time so we can move on.
Commissioner Khan?
Thank you. Thank you. I just want to agree with Commissioner Slonim that I believe that that healthcare cost is already going to be assumed within the Peterson-Milbank program in that advisory committee. And so I really think, to Commissioner Sloan's point, that we really need to focus on the patients and quality of care for the patients, access to care for the patients. And if we were going to do an additional one, and I agree with Commissioner Bond too, that, you know, let's focus on, you know, the Milbank Peterson Advisory Committee and the work that's being done there, because that's going to drive a lot of conversation around cost, affordability, all of that. But I do think, you know, we as a Patient Protection Commission, we should be looking at patients and impacts to patients and the quality of care that they're receiving. So I agree with that we should limit it.
Who's the next commissioner online?
Okay, great. I don't have any other commissioners' hands raised, so I'm just going to go. Looks like actually Jessica, Commissioner Flood.
Oh, I thought we were just going down the line. So Flo, and hoping Bohannon, and then me. That's all.
Sure.
Who's next?
So the next person on my list, if we follow that, would be Dr. Barron.
Okay, Dr. Barron, Commissioner Barron.
Okay, I would agree with making workforce a priority. And I would agree that network adequacy is covered in the Network Adequacy Advisory Council through the DOI. And I would agree that cost is being addressed through the Peterson-Milbank program and should not be our top subcommittee priority to set up right now. I would like to eventually see a Medicaid subcommittee to focus on all aspects of Medicaid. And I think Commissioner Bond stated it well, that this is a whole entity unto itself and requires a lot of thought and process and deciding what we really want to come out of that type of work subcommittee. So workforce would be my top priority in addition to the Peterson-Milbank project.
So if I may narrow this down, how many people who have not spoken and the others who have already commented, if there was one other subcommittee to be considered besides Milbank, do you want that to be workforce development? Please raise your hands. How many would want workforce development as the next committee? Sarah, can you count?
I'm fine with that.
Okay, so it looks like this is a little bit hard for me. So it looks like, can you please just do it virtually, everyone? It's just easier than the screen. Let's give it a moment. I think we're all familiar. Commissioner Flocon, can you, so no, okay. So everybody who has their hand raised is, and I'm gonna say this by last name, Shaner, Roa Dugan, Slonim, Bohannon, Barron, Bond, Van Howling, and Flood.
Can I just make one more question or comment? Because I appreciate that. Just that the quality piece, I wonder if we could have this be part of the Millbank conversation, because Mr. Baylett did talk about how Delaware had quality measures. Wasn't it Delaware that also considered quality measures in it? So I just wonder if that could continue to be part of that conversation of the subcommittee, or even our work in that.
So I would suggest Mike come back to us when he presents next time the process, etc., if he wants to plug in quality. So I think we have a majority saying that second committee that we may want to consider once Millbank is sorted out would be workforce. I think I counted 8 people, perhaps including myself, 8 or 9. Correct, Sarah?
I believe that's right. I think the only 2 commissioners, was it Commissioner Flo Khan and Van Howling? Sorry. I think that might have been accurate on the vote count, but you did have majority of commission agree.
Okay, so I think we need to move on to the next item. Number 10, update on commission spending legislation. Brief,
Okay.
please, Sarah.
Sure. And I just want to make sure that there was 5 commissioners. I don't think that had a chance to opine on that discussion. But is everybody okay for us to move on?
Did we miss anybody who had raised their hand or in sequence?
We missed in sequence. Is there anybody now that wants to raise their hand to speak on that? I just want to make sure we're fair to everyone.
Well, if I could just say, I mean, that was like a little bit of a forced vote on workforce, and I'm sure everyone has a couple of ideas. But so, and we also were like, oh, okay, we're just going to have one extra subcommittee. No one had any chance to talk about anything else. But if we could have 3, if I could just give my comments, it would be Millbank, workforce, and quality. But I don't know if that matters at this point.
Okay.
Nicely stated.
Can we maybe put it on the agenda again and have a richer discussion about subcommittees? Because this is 2 times now that we really haven't defined what the subcommittees are going to be. And I feel like it is kind of rushed, and it'd be nice to have.
So the subcommittees, if I may answer that, are not limited. The only thing I voted on is whether the next subcommittee we would like to focus on. That doesn't mean excluding other subcommittees at this point in time. So at the next meeting, we can come back and say, okay, workforce, and the discussion can continue what to add, subtract from the workforce or whatever. So it's the next committee that we think should be the workforce committee, but the other committees can also come in sequence or combine or whatever when we deliberate next meeting. So it's not a closed subject, but say today. So it's a continuation of the subject. All right, Sarah.
Okay, thanks, Chris. I will try to be brief, and I might give you just a 2-minute quick update. I think that you've been receiving multiple updates from me on the pending legislation weekly. I will continue with that this week and give you a deeper update, or of course, I can always answer any questions that you may have. The legislature just finished with one of their biggest deadlines, which was first House passage last night. I'm happy to report that both of the bills survived that deadline. Both of the bills have been amended. Senate Bill 5 is actually in the opposite House now in Assembly. That bill moves forward without a fiscal note. Senate Bill 5 does have a exemption. So that bill is still in Senate, and I expect that to go next to the money committees to discuss the fiscal components of those measures.
Sarah, you just said Senate 5 both times.
Oh,
Senate 40
I'm so sorry, Senate Bill
right?
40. I'm sorry, I'm rushing. Yes, I'm sorry. Senate Bill 40 has a exemption with it, and so that one is still in Senate, and my expectation is that it's going to go next to Finance. And then the next, just so I want everyone to make sure that the next major deadline, I think, is May 14th, and that is second House passage. Right now, Senate Bill 5 is the one that would need to be mindful of that deadline because it is not exempted from deadlines.
Actually, if I can make a correction, That's committee passage. Second
Committee
House
passage.
Second House passage is the 20th of May.
Thank you, Leslie.
Thank you.
So
So
I
that,
have
Sorry,
a minute to
21st.
answer, the 21st. I have a minute to answer any questions, but commissioners, you can always respond to my updates weekly or connect with me separately if you'd like a deeper update or would like to discuss.
I think in the interest of time, that's what I would recommend. And I think,
Can I raise one issue, Chairman? I just want to, there is another bill that's going through the process that has to do with the PPC Commission. It's AB 348. I would suggest to the commissioners that they take a look at that bill. It does a few things, including changing the membership of this committee or of this commission. And it also has some other provisions in there that I have personally, as a commissioner, I have concerns with, but I do think it's something that we should review and potentially have a discussion about at some point on the next agenda. Thank you.
all right, thank you. So on the standing agenda, let's see. So on the standing agenda items, discussion of potential agenda items, my suggestion there is, as always, we can, the commissioners can submit their agenda items that they would like to discuss at the next meeting to Sarah, so we can include them. And in terms of future meeting dates, that also, I think Leslie does a good job in sending out options to everybody of dates. And then if the significant majority is in agreement with a particular date, then we can narrow it down to that. But I think, wasn't the monthly potential dates already sent out, Sarah?
Yes, and I believe there's still agreement to maintain every third Wednesday of the month. And so your next meeting is scheduled for Wednesday, May 19th at 8 a.m. unless you choose to not stick to that date. And that's also agendized.
All right. Public comment.
Hold on. Okay, so members of the public, if you are joining us via Zoom, please raise your hand now to be added into the queue for public comment. If you are on the line via phone, I believe you can press *9 to raise your hand to indicate that you wish to speak. So Chair Khan, if we can just give members of the public a time to speak.
Yeah.
Okay, it looks like we've got one person so far. Hold on, I will let them in. Miss Allison Barco. So Miss Allison, you're unmuted, but we can barely hear you.
Sorry. We just wanted to, I'm Allison Barco from the Hemostasis and Thrombosis Center of Nevada. We wanted to thank you for your work and just comment that while bills such as SB 40 are the first steps we have conveyed to payers such as Culinary and Health Plan in Nevada, that our federal data shows that we reduce mortality and morbidity by 40% and reduce costs. And yet that data has not assisted with improving access to care for these patients who continue for the last 4 years to pay cash to obtain access to the state's only center of excellence and designated center for hemophilia. We look forward to assisting in any way we can to improve access for these patients and improve our network adequacy.
Thank you. Any other comments? Please restrict your comments to no more than 3 minutes. Is there anyone else, Sarah?
Let's just give the public a moment. Again, if you're joining us by phone, please press *9. Chair Khan, I do not have anybody else wishing to speak during public comment.
Okay, thank you. I think I really want to thank the commissioners. I think we accomplished a lot today, and the best accomplishment is we are like 6 minutes ahead of schedule. I think that's the major accomplishment. So thank you everybody for your time, and I need a motion to adjourn.
Make
So
a motion
moved
to
by
adjourn. Oh, second,
Okay.
Ms. Bond's motion.
Okay, any opposed? If none, We stand adjourned. Thank you very